excited to be here with you all today. So we are going to get started with our panel around doula access. And it's so exciting to hear about the work that was already being done before the word doula became more popular, if you will, and mainstream. We know that this is not something new as it relates to the work that doulas have done, particularly in Black and Brown communities. It has been a role that transcends generations. So that I'm going to ask our panelists to join me on the stage here. Natasha, Stephanie, Dr. Bronner, please join me up here on the stage so that we can continue this conversation around doula access. Give them a hand, please, while they join. There we go. Thank you. Our mics are ready. So as they're approaching, one of the things I wanted to ask is who now, of course, it has become more common knowledge. You ladies can join, please. I think they're going to move the podium so they'll be able to see us. Okay. Thank you so much for that. Who had heard of the word doula before a lot of what has been coming along mainstream? Had you heard of the word? Show of hands. Who's heard of the word doula before? Okay. So one of the things that became one of the ways that I got introduced to the concept, you hear about it all the time, people that support it during birth, wherever they may have chosen to do so, home birth. For me, it started out of my own personal journey. About 12 years ago, while I had my first child, I have two junior interns, one 12 and one now 4. But with the first child, I remember after having her, I felt totally disconnected. But that now perpetuated and sent me spiraling out of control because I felt like an awful mother. Because I'm like, what mother struggles to connect with their child? What mother has difficulty seeing the value that they bring to their own child's life? And it was because of someone recognizing that there was a gap there was a challenge with me being able to focus in and notice and said, hey, it looks like something's wrong, that literally saved my life. Because at one point, that was the question I was asking is, would it be better for her if I was not here? Now, at the time, I did not have the language to describe what that was, and then later learned that I was navigating postpartum psychosis, anxiety, and depression. But imagine having someone that was walking alongside with you. Now, we know them, again, as auntie and grandma and cousin as we went through these experiences, but there's a word, doula. It's a Greek word, so that's why for some of us, we're like, what is that? But you've also heard it referred to in various forms of birth attendant and companion and keeper. And so what we're here to talk about today is how doulas can really support through this crisis. Now, one thing we are quick to say, disclaimer, doulas did not create this situation that we are navigating, so we are not saying that that is the solution in and of by itself, but there is some value I'm sure you all will be able to share a little bit about. So if we could just briefly introduce yourself and what your calling is or your role is in this work, and we'll jump right into these questions.
So I'll start. Good morning, everyone, and thank you for having me. My name is Natasha Turner. I'm the doula program analyst with the Department of Medical Assistance Services, or Virginia Medicaid. And my role with Virginia Medicaid has been to help implement the new, or fairly new, doula benefit. And so working with the community, working with the doula organizations, working with our champions such as Urban Baby Beginnings and Birth in Color, RVA, and the doula, the collective doula voice, and our healthcare plans and our key stakeholders. So really just working in this role so that more women can have access to this service.
Good afternoon. Is it morning still?
It's
morning. Hi, my name is Stephanie Spencer. I'm the executive director and founder of Urban Baby Beginnings. And my role in this space is to ensure that communities are supported and that their voices are elevated in the work that's happening around them. I'm a registered nurse by trade, mom of three, but also a person who experienced my mother losing a baby as a result of uh, poor care. And so I always want to make sure that when we're trying to elevate voices in communities, that people understand the devastating effects of loss and what can happen. My work has spanned across many different sectors, but mostly the role that I play currently at the state level is helping to inform the work for doulas, supporting expansion, training workforce, developing and implementing programs between hospitals and clinical systems to provide connections from hospital to home, and kind of a lot of other things in between. So I'm happy to be here to, one, recognize this issue that is so important to all of us, but also to continue our support.
Good morning. My name is Yvonne Bronner, and I may as well get out of the way the thing that's most important. I'm the mother of three and grandmother of six.
Ooh.
And so really proud of that. Today I am here from Morgan State University and a major investment that the Biden administration has made in maternal health, the $90 million. Well, I'm so pleased that I am the project director of what is about 50 million of that among our 16 institutions around the world, around the U.S., and I will be sharing about that. And we were fortunate at Morgan to train 40 of our students in our master's program in the doula program, and this was my first understanding, frankly, of the doula program and all of the good work that they do. So I am so proud to be able to also represent that interest. Thank you.
That is so awesome. It's one thing, you hear a lot about the budget and what information has been shared, but to see that it's going to the community, in particular those who are doing the work, is super exciting. So I'm going to start with you, Natasha. And one of the things too, I want you to keep in mind. Please take notes. Please write down different ways that you can see yourself weaving. You may not decide to become a doula one day, but you're going to hear so much expertise and wisdom that it's going to start to show up in other areas where people who may be interested in joining that movement and joining the workforce. And Black Maternal Health Week is just 2 days away. So that's another reason and way that you can help champion for this work. So Natasha, I'm going to start with you. If you could, just share some broad demographics, some information, if you will, about the women and the families who tend to seek doula services in the Tidewater area or in the areas that you serve.
Thank you for the question. First, I just want to share overall to date in all regions, not just the Tidewater region, there have been 372 Medicaid members who have received doula support prenatally, throughout pregnancy, and or in the postpartum period. There have been 168 doula-assisted births to Medicaid members. And based on the data that we do have for Medicaid members who have received doula services, most members were between the ages of 25 and 35. It's important to note that Virginia Medicaid is a new benefit for DMAS. Therefore, the demographic data for members receiving doula services is not currently available. But what I can provide is the demographic data for pregnant, and this is just for Medicaid members, pregnant Medicaid members residing in the Tidewater region. And so based on Medicaid enrollment and famous enrollment, and then again, it's not the total number of Medicaid members receiving doula services, but of the pregnant women. As of March 15, 2024, there were 7,177 pregnant Medicaid members residing in the Tidewater Eastern region. And of the 7,177 members, 93% were non-Hispanic, 7% were Hispanic, 40% in terms of race, 40% were white, 51% were Black or African American, 3% were Asian, 3 classified themselves as other, and 1% American Indian or Alaskan Native, and 2% were Native Hawaiian or Pacific Islander. And then in terms of age, in terms of the pregnant women in the region, in this region, 79% of the pregnant members were between the ages of 20 and 34. 18% of the pregnant women in this region are between the ages of 35 and 64, and 3% of the pregnant members are under the age of 19. So that just gives you a little bit of the demographic of the pregnant Medicaid members in this region.
Thank you for that. And we're going to talk a little bit more about how quality and improvement in those areas for those moms in particular has started to happen through the work that you're doing. Dr. Bronner, I wanted to come to you. Interestingly enough, last year we had an opportunity to work with one of the doulas that came through your program. She actually supported in some of the work that we were doing too with Cocoa Life. And so I wanted to ask, through Morgan State, so you're still part of the DMV area, but through the work that you are doing at Morgan State, what has been the impact to those communities in that area? Because I know that's very close to the Baltimore area. How have the work you've been doing supported that maternal health space?
You know, when you mention the word impact, that's a little bit challenging in terms of measuring, because the work that our students are doing, and the thing about our program, I mentioned that it was 40 of our master's students, and that was a unique group of people. And so what have they done? They've actually done a lot of work on campus and around other campuses. And of course, the first thing they report is the impact, and speaking of impact, the impact it has had on them, because they are in a family formation time of their lives. And so most of them either had children or were in the process of thinking about a family. And so they speak often about the impact that this tremendous amount of training has had on the way they view themselves and this family formation piece. Emphasis there, because you know that more than half of all pregnancies are not planned, and we know how important it is to plan a pregnancy and a family formation. So I can, as a longtime person in home economics, in maternal and child health, that is a very important first point that I got from their impact. Now, the second point is that they're sharing this with their male constituents. And on our campus, that's another part of maternal health that is often overlooked. And a part of my early research was about the male role in breastfeeding promotion. For any of you that are WIC participants, you know that the videos that we made and that continue to be used were highlighting the male role. And so that's a second component of the doula work that we think is important, because it is about the family. And what a lot of the young men are saying is that nobody has ever taken the time to speak to them about the pregnancy, about their role, and about the support that they can give, like a second doula. And actually, we had a male doula. And so that was another very important aspect of the work. And then I think finally, what has happened is the impact that they have had on the concept that master's trained people who were in the process of trying to graduate would take time out, because this took most of a semester for them to be trained, and that they would spend that time and then look to impact their community, their constituents, and their friends. So it's been quite useful.
That's wonderful. And I love that you brought up the importance of paternal health. So one of the things we say when we're talking is we can't talk maternal health without talking paternal health. One of the organizations that we partner with, Daddy University, always says that for so long, the obstetrics room, the space of maternal health, was treated like the women's bathroom. And so for years, they were told, you do not go into the women's bathroom. But now we need to create a space where all of the persons that are a part of the care team are aware of how to make sure that dads are engaged. So as doulas, making sure that their voices are heard and they're seen, and then even those care team members are present with that too, with that same mentality. And that brings me to a question that I had for you, Stephanie. With Urban Baby Beginnings, so you're also a perinatal safe spot through Common Sense Childbirth, right? And so we are very appreciative of the work that Mama Jenny Joseph has done throughout the years. We're also a perinatal safe spot, and that means that there are what are considered maternal toxic zones all throughout this country, areas where it's important to make sure that there is safety and there's a place that women can go to, birthing persons can go to connect to make sure that they are receiving care, being seen, and care isn't reduced to just the clinical side of it. I always say with Philadelphia, you can throw a stone and hit many hospital systems. It's not just access, right? I can get there, it's what happens when I get there. So along those lines, when it comes to training for your staff, what is it? What sort of training do they go through to make sure that they are providing not just culturally competent, because you can be sensitive to others' culture, but how to make sure that they're providing the most inclusive, compassionate care to those families that they're serving?
Sure. So thank you for that, and also recognizing the work that's happening across the United States to build safety and support and systems. Here in Virginia and at Urban Baby Beginnings, we have really put a lot of effort and energy into building a system of education and support for our doulas in the state of Virginia. We do have a requirement if someone is going to train to become a state certified doula, or even be able to accept Medicaid, that they receive a minimum of 60 hours of education related to multiple topics in the maternal and child health space. Now, I will tell you that we are a Health Connect One affiliate. What that means is that we provide 6 months of training to our community individuals who are providing support to members in the community. It looks a little bit different, but the reality is that the first step is really identifying trusted members in the community who have lived experience as a first precursor to them being able to serve in the community as well. I would say that our training is very robust. I just finished talking to a couple of our trainees that said, I made it through the first couple of weeks, and I get it. But the reality is that to be able to keep people safe and to be able to advocate effectively, you have to know what's actually supposed to be done so that you can advocate when something doesn't look right. And as a registered nurse, I try to pour that energy into folks in Urban Baby Beginnings to make sure that they can do just that.
Thank you for that. That's important part of the work that's being done. And when we think about advocacy, it's never about speaking for the families. It's exactly what you said, being able to recognize that. When we embarked on this journey through Enon, through our church, as Melissa was sharing, to launch our doula ministry, a lot of these things, similar to our own work, come out of our lived experience. So I shared a little of mine. One of the things I always say, too, is that I decided to become what I didn't have at that time. And so that was really what mobilized the ministry to say we could see what was happening in our communities. And it is the church's responsibility from a faith-based perspective, or any faith-based organization, to step up where we see the opportunity. We always use this language, it takes a village to raise a child, but who's supporting the village? And for many of our communities, we've been disempowered through so many different systemic experiences that we needed to re-engage that power. And that was one of the ways, starting a doula ministry. And so we set out to train and certify and provide support through many levels. One of our trainers is here today. And it was showing not just what does it look like for you, but what sort of space do you want to create for someone else? So how can you be for someone else? And so that's where, too, we learned and developed this term called a mombassador. So again, doula may not necessarily be the track. You're like, I don't know if I want to sit and just do this one lens, but all of us are mombassadors. We all care about the work that is happening, and we care about the outcomes. And to do that, whether it's an allyship or what have you, that means you stand in front. That means you speak up when you see challenges that are happening, and you are a part of those solutions too. And so thinking about improved quality care and kind of what it means to create a system. So we see what systems do when they're not supportive of these improved outcomes. So from your lens, Natasha, what are or how do you create a quality care system for these families that you're serving? What does it look like to provide support for those pregnant and expecting families postpartum, and making sure that they are able to thrive throughout these experiences too? Thinking about what the efforts that come in when you think about perinatal quality collaboratives too. So what goes into that in creating a system that is going to help women thrive?
It's a big question. So I think the first thing is really just working together. It's not just the state. It's not just it's everybody. It's the community's voice, understanding the needs. It's working with our stakeholders, our healthcare plans, everyone across the board working to improve our state partners working to improve the outcomes for women and children. In terms of our perinatal quality collaboratives, so in Virginia, the Virginia Neonatal and Perinatal Collaborative, VMPC, serves as the PQC for the Commonwealth of Virginia. It was established in 2017 to improve maternal and infant health outcomes. And so some of the ways that DMAS supports the VMPC is really through the maternal health hub task force, a partnership to support the community voices around maternal health, monthly the interagency collaborative meetings that we have, which include several of our partners, maternal health work groups. It's things like the doula benefit and supporting moms in having access to a service that they wouldn't have. And I just want to kind of mention really quick that the doula benefit provides 4 prenatal visits, 4 postpartum visits, support during labor and delivery, but also the 12 months postpartum coverage that allows women to have continued support, extended benefits, to have dental coverage. DMAS offers several benefits to support pregnant women, lactation support, prenatal and postpartum care, mental health services, transportation services, food services, all of those things that support families. The healthcare plans have added benefits. They provide food and diapers and baby showers and things like that to support. So it's all of us working together. And I just want to point out one of the projects that the VMPC had called Turn the Page. And it was it's a project, and if you have time to Google later, VMPC, but it was a project that brought real families that had real experiences and shared their stories. And it was really, really powerful. So it's really about all working together, all supporting, knowing and understanding and hearing the needs to the various communities, because across Virginia looks very different. Here in Tidewater looks very different than Southwest, looks very different in, Northern Virginia. We have urban, we have rural, we have coastal. So understanding the needs for particular communities, because they are different. So I think that's part of it.
Thank you. And thank you for lifting that up about the importance of tailoring the care, being specific to those who need it and not this cookie cutter or one size fits all approach. And there is a way to do that. Sometimes it can feel overwhelming, like how do we serve the masses in this intentional way? But you've all found a way to do that. And I think that that's important. Stephanie, I wanted to see if you could take a moment to describe the concept of rebirth and really how important it is for families to be treated, as particularly in communities of color, to be treated by professionals of color as well.
Absolutely. So 3 years ago, we brought forth a project here, or program here called Rebirth, a new beginning, really, for families of color. And we wanted to elevate the fact of the importance of ensuring that paraprofessionals of color were available to communities of color as well, and that we needed to ensure that families had access to these individuals. Because it is important. I was talking to some of our moms about what they really wanted to see in our programming, and the one thing that continued to come up over and over again was the fact that they felt like they had a sense of belonging in a space with people who looked like them and who had been through similar journeys. We know, statistically speaking, there are studies that show that having professionals of color serving those members who are also individuals of color changes outcomes. The relationship is different. How I talk to someone who I identify with is different. And so Rebirth is really trying to capture that to ensure that we're elevating voices, that we're bringing trusted members from communities in, providing workforce that is reflective of the communities that we're serving, and ensuring that individuals can access those services. Rebirth is a concept that takes individuals, whether it be ground forces or telehealth, and it brings them all together to be able to support people. Our program, I would say over 90% of the individuals that we serve are families of color, and that's why this is also something that's extremely important. There are a couple of ways that we support our families of color and looking at our paraprofessionals who are doing this, and we have social workers and qualified mental health professionals that are doing this work. We have doulas who also specialize in maternal mental health, just family support in general, lactation, and nursing. And all of them are individuals of color as well. I think if I were to share more about the communities that we have served over time and the amount of work that we've done at the community level, I would definitely say that over the time that we've done this work, that in building things that belong to the community, that are informed and supported by the community and are reflective of the community, that we've been able to see differences and changes and outcomes as a result of all of that. And so Rebirth, it means something, yes, but also in application does something. And because of this, we've been able to change outcomes, reduce preterm births, reduce trauma in systems as a result of poor care. We've ensured that our families have this wraparound services and support, and have this relationship with those who are serving in this capacity, so that we can also identify when there are other things that we need to do. And as a result of Rebirth being a concept within this area, we've actually been able to inform a lot of the work that's happening for women in this community more specifically, but other communities across the state. So I think, just in summary, really reminding ourselves that, you know, when we're working together, it is still extremely important to really recognize that there's power in familiarity, and there's power in relationship and engagement with people who look like you. And that's something that we can't take away from communities. We can only just continue to build.
Thank you so much for that. I wrote down everything you said was powerful, and I wrote down because it's just stuck out to me. You know, we always try to put something on a T-shirt or a pillow, but the work we do, it means something and it does something. And so I think so often we got to be reminded of that ourselves as maternal health professionals, public health professionals, birth workers, however we show up in this space, is that it means something and it does something. And so if it's not doing those two things, if it doesn't mean anything and does something, it's got to be both. It's not either or. It can't mean something but do nothing, right? We were just talking, Dr. Bronner mentioned, it's hard to measure impact in this space. We know what the data says, and it's tons of numbers, but what we also get a chance to do is pause here for a moment and say, but behind every last one of those numbers, and it was mentioned earlier, as we think about Mama Kara, it's lives behind each one of these. It's families that's behind each one of these. So when something doesn't mean something and it doesn't do something for these families that are being served, we're going to keep seeing the data go in the opposite direction. And I know I can speak for all of us here when I say that that is not the goal. We did not come here, drive here, show up here, however we got here, just for it to stay where it is. And so with that, when we talk about maternal health, and you mentioned it earlier, Dr. Bronner, about how important it is to include fathers in it. I shared my journey, but can you talk a little bit about, too, the mental health aspect of it, and how positive the influence can be, the impact can be, when we also not forget about having a lens that focuses on mental health too in this maternal health landscape?
Well, I want to first say that I am not a mental health practitioner, so I don't want to go out there. Although my daughter is a psychiatrist, she keeps reminding me that I'm not licensed. So don't go there. But we do know that one of the major findings from WIC and their early assessment process has been the fact that in this postpartum period, we have a lot of mental health issues. And that goes back maybe 30 years. And then since that point, I think there's been an emphasis on understanding the impact of one identifying, as you pointed out. Mental health is something that has had a bad rap in many communities, and in particular our community. And I was sitting at the table speaking with the lady who was beside me, and she was saying we both admitted that we hide a lot of things. We have hidden, and mental health issues are one of the things that have gone hidden. And one of the great things that about COVID, if there's nothing good that could come out of COVID, but one of the things has been our comfort with the notion that many of us, in fact, maybe most of us, may have experienced some slight depression or anxiety, separation. Being away from people has helped us to understand the impact of mental health. And so with pregnancy and all of the physiological changes that happen, and then you have that postpartum period, our ability to appreciate, identify, and now treat the whole mental health is a huge asset. And I don't know really that there's a lot of science behind this, but I do have been hearing a little bit more about the problems that men are facing as they transition through various periods. And so I think this is another piece that we have to maybe put on our radar for research. And one of the things I want to just say here while we're talking about Morgan and this $50 million that we have to invest in maternal health research. One of the projects will look at doulas, and the project at Morgan State University is one of the ones that will address the whole doula piece. And one of the things about what they're hoping to do is to be able to standardize measures and to be able in the next 5 years to have a lot more research and statistics on the impact, so that we're not talking anecdotally, but that we will have science to back us up. And so I do think that the doula being right there is a very important piece of identifying. Because, see, that's the big problem. When you're in the midst of all of this, you don't know what's happening to you, and you can't identify it. So having a person there to help you identify it is the first piece. And then the second piece is to say, you're not alone. You're not the only one that is experiencing this. And you're not the first one, maybe not even the first one in your family who has experienced this. And the third piece, help is on the way. And you know we have the help, the hotline that we have now, and I don't have that number right in front of me, but I'm sure some of my colleagues up here may have that number. But the hotline is a way that people don't have to be afraid to call it. They don't have to identify to call it. And you know, that's a big part of mental health. We don't want to let anybody to know that we have this problem. So sometimes that prevents us from seeking services. So I do want to point that out, and I'm sure that you will say more about the hotline.
I can. The hotline number for the National Maternal Mental Health Hotline number is 833-TLC-MAMA. So that's 1-833-852-6262. We are constantly sharing it. There's also, I know a couple of years ago, I think it's been 988 was released from the federal government, from the HHS. You can call, you can text it whenever you need support, and that way too. There's cards. We have information that's out there at the front as well. And it's important to have these resources. So when people ask me to kind of describe what does a doula do, they're like, what's a doula? What's that? Outside of going through the different components that we've shared here today, my first thing is that we're non-medical. So just to reinforce that, even while some may be nurses, midwives, and clinicians of other spaces, when we move and operate as a doula, it's not to try to provide medical advice. So the scope of a doula, I always say SCOPE, is to support, to be a compassionate companion, to organize, to prepare, and to educate. And 99%, 100% of how we educate is through just what Dr. Bronner was saying, which is referrals, connections to information. That doula may be the first person to interact and have that experience, in addition to preparing the fathers and partners that are in this space to recognize some of these signs. That's why a lot of what we do through some of our maternal mental health champions is teaching doulas how to screen. Not screen like a clinician, because again, we're non-clinical, but to be aware, that sense of awareness so that you can make those connections, I think is so important. So thank you very much for sharing that. And another great resource is the Maternal Health Policy Center. It focuses on a lot of the work, shares a lot of data that we're talking about today as far as how mental health impacts our community. And the more we can do this research, align it with the solutions that are being talked about here too, it's going to help us get more positive data that will keep the work moving forward in the right direction. So, Natasha, I just wanted to come back to you to also share a little bit more about prenatal care. So some of what we also learn in data is that sometimes in communities of color, there may be missed appointments. There may be, and that could go back to what Dr. Bronner was saying earlier about the data that showed not a lot of pregnancies, experiences are planned. So then you find out that you're expecting, similar to I did, which was like about 6 months or so after my mother had passed. And so you think about where your mind is. So I'm already not recognizing it then again, but I'm in this state of grief. I was working in a very toxic environment for work that was not very friendly of women and the needs of the women during birthing experiences. So now I have that challenge. And so I got to admit, and this was me at an executive level position. I was an AVP at the time. I did not make my prenatal appointments some of the times because sometimes I just couldn't even get myself up and go. One was for a fear that I was like, if I go to this appointment, that means I can't get to work, and I need to work because I have this responsibility here, and I'm still taking care of things for my mom too. So how important though is prenatal care, and what are maybe some solutions that you found to help make that more achievable of an outcome, because those early stages are so crucial?
So, prenatal care is critical. It's crucial. One, for healthy pregnancy. Early and regular visits significantly improves the chances of a healthy pregnancy. Reduced risk of low birth weight. Women who receive proper prenatal care are 3 times likely to deliver, or women who receive proper prenatal care are 3 times likely to deliver a healthy baby. Infant survival. Regular checkups, monitoring, help to manage potential risk and help to create an environment, a healthy environment for the baby. Preventing complications. Going into the prenatal visits, you can identify and manage early things like diabetes, high blood pressure, anemia, infections, depression, gestational diabetes, things that could potentially have an impact on the pregnancy later. And then even if a family is even thinking about conceiving, even preconception care, getting your body healthy, nutrition, all of those types of things are really important. And so DMAS, because Medicaid recognizes the importance of prenatal care and healthy pregnancies, DMAS encourages its providers and is encouraging its providers to offer non-traditional hours in the evenings and the weekends. We have worked with providers in a particular community that started to offer Saturday hours. And so we have found that that has opened access to care for women. DMAS also offers transportation services to individuals and help in getting to the appointments. So really, prioritizing prenatal care is really essential for ensuring a healthy pregnancy and ensuring the health of the mom and the baby.
Thank you for that. And it helps so much when you talked about prevention. Sometimes when we hear about things like gestational diabetes, heart disease, any of those things that came as a result of the expectant experience, that pregnancy experience, we think, oh, well, as soon as I have the baby, it's done. No, there's a lot that can stick with us if we're not careful about what our experiences are. That's why it is so important to be informed about our family history, even in those things that can impact us, and recognizing that when we talk about these statistics of mortality and morbidity, right, we understand mortality and fatalities are devastating. And then also, too, we have to think about those morbidities and those things that can stick with us for the rest of our lives if we aren't careful about how we care for ourselves during this period. So,
Sorry, I just
No,
wanted
that's
to
it.
tack on. And, you know, doulas can actually help a lot just in the pregnancy journey. We talked about identifying things. They're the eyes, they're the ears, walking along with the woman, helping her to, you know, encourage her to go to appointments or helping her understand what's going on with her body. When you think about it, you know, we don't learn about our bodies or pregnancy or any of that in school. You might have taken like one health ed class. They separate the girls, they separate the boys, but they don't talk about pregnancy. They don't talk about the changes in your body. They don't talk about all of the things. So a lot of time, and sometimes, you know, our OB providers and our providers are great, but sometimes they just don't have time to provide some of that childbirth education, what to expect for labor and delivery. And so that's when some of these resources that we're talking about in doulas can help provide some of that critical education. So, sorry.
no, thank you for that. And it is, interestingly enough, I was talking to, again, one of our doulas who has also helped me to understand the importance of making sure that we don't forget about our just as involved moms and families too. And Natasha has been instrumental in sharing about the importance of doula work and how we can't separate out childbirth education. We can't separate out being mental health informed, mental health aware. We can't separate out some of those things in the work we do because it will help us to build that connection. So I have one final question for each of you to share before I open it up to see for the audience as well. So thinking about the workforce, our maternal health workforce, it is very underserved, and there's many things that may impact that. Diversity. We talked about the importance of diversity in that. Throughout the United States, we are seeing more and more information and insight being brought to, again, the space of the doula workforce. But how, when we talk about sustainability, because that's one of the things we say, it's great to think about development, but you also have to think about sustainability in that. And so due to low reimbursement rates and the lack of coverage from insurance, there's also a short supply of non-clinical professionals like doulas. And so one of the questions that I wanted to ask as a final question before we open it up to the audience is, how do we work to increase the birth worker workforce, that perinatal workforce? What would be one of the things that we should do, and maybe you're doing it now, that we can do to help increase that workforce? And I'll start with you, Stephanie.
So thank you for that question, because I think it is really important, and it is a conversation that's come up across the United States about how do we retain our workforce, how do we bring new workforce in, and the reality is that when we don't build the reimbursement, when we're not supporting our foundational programs, it's hard to manage maintaining workforce. I had a provider once sit and talk to me, and he said, you know, the doula, one of the doulas in general, I saw her arrive at the hospital, and the baby was born a couple of hours later, but the mom had been in the hospital for 2 or 3 days, and she should have been here for those 2 or 3 days. And I said, well, that's not the reality for doulas. They can't do that. And so when we're talking about building workforce and ensuring that people are available, we really have to be thinking about that. At Urban Baby Beginnings, we built this maternal health hub to provide that foundational support for doulas, to encourage them to seek support from our social workers, from our team. We have a clinical engagement manager and others who are there to ensure that they're able to hear what's going on the ground level and to continue to build so that we're supporting the individuals who are doing the work. I also think that it's important to think about how do we build workforce so that they can do this in a full-time capacity. Because how we built Medicaid at this point in time does not allow for that. What happens is that the doula does a birth, they have to wait some time to get paid, they've taken off work, they've paid for childcare, they've paid for transportation, and all these things have happened before they've received payment. And when we're talking about building workforce and the majority of the individuals have the same experiences as the clients that they are serving, there are already barriers and insurmountable barriers that they're having to jump through and over in order to even get to that one birth. And so we're really trying to address that because people deserve access to health care, and they deserve being able to have time off and mental health care and all these types of things. But it's impossible to do that the way we've structured our programs today. I also want to say that the other thing about retaining workforce is it's important to recognize the mental implications to what happens when you have to go into a birth space and watch someone not be treated well. And remind yourself of what happened in your traumatic birth, which brought you to become a doula. And now you have no way of really processing any of those things. And what happens is a lot of times people who are traumatized in those types of environments, their trauma comes back to the forefront of what's really happened previously that hasn't been addressed. And as a result of that, we lose workforce because now I'm in it and I realize I'm not even ready. And so we have to think about how do we build systems of support for doulas, protective factors. How do we encourage systems to build around the fact that these doulas are coming in? Because I hate to see when a doula arrives in a system of care and is not supported by the very providers that they are telling people to trust. And then lastly, how do we continue on to make sure that people can continue to do this work and to thrive in the community? So those are some of the things that I would say. Thank you. Dr. Roddick.
Well, one of the things that, I've been around a long time. So I started with the community health worker. And now we know that the community health worker is in some places full-time, and in some places with benefits. And most of us who are in the room work full-time and we get benefits. So this is not a rare or strange construct. So why is it that we are so willing to have the people who do the most important work not be full-time and not get benefits? What kind of place are we? And then we look at the outcomes and we ask ourselves, why are we getting these outcomes? The question is, why aren't they worse? And so there are a couple of things that at Morgan we're hoping to do in our 5 years of work on the doula construct. The first one is to move back to preconception doulas. Now, many of you have spoken to the fact that many of our women are coming into pregnancies with chronic diseases. And so the pregnancy is only 9 months and often 6 months or later when you finally find out so the time period during pregnancy is not long enough to make the kind of impact that health status can have on the pregnancy outcome. And so what we are advocating is a preconception doula construct, where we would have doulas who would begin to work in community with community health workers, but their focus would be family orientation and planning and the kind of things that they would do at a postpartum period, but at a preconception period, identifying issues that mothers might be unaware of, fathers might be families might be unaware of, and starting to plan around removing some of those barriers before the woman becomes pregnant. Second, of course, is to plan the pregnancy. And so the doulas would be instrumental in that regard. So the second piece is then documenting the impact of their work from a statistical perspective so that we can say to the community of people, because you had mentioned, how is the doula perceived when they go into the hospital? And we know, well, I don't actually do this, but I hear them say that they're not perceived well. And why are you here? And you're in the way, and blah, blah. And so what we've got to do is improve the understanding of the doula's role and allow that role to be perceived and understood by the coworkers so that when they go into the setting, they are respected for the work that they do. And then that piece can be a part of that full-time employment. I mean, how can you expect a doula to not be full-time, actually around the clock full-time? And so we need to write all of that in. And then paid a working wage. I don't know about your doulas here, but I hear that they're not being paid a living wage. And so a living wage is very important. And this is really a big piece to sustaining any workforce. A workforce has to, at the foundation, be paid. They have to be educated, certified. That came up a few times. We have to certify them so that there is a certain level of expectation that we can have when we bring a person into the setting, because we don't, if they're not certified, then how are you going to know who you're walking in the door? And so I think we have a lot of work to do in terms of standardizing, certifying, broadening the role across the life course, and then making sure that it is paid and supported at a living wage level.
Thank you.
So I think part of it is really continuing to have meetings and forums like this one. The community voice, our voices, the voices of everyone is it's important. The Virginia Medicaid benefit came to be because of the voice of the doulas, but because of the voice of the community. So I would say really continuing really to educate and have forums like this and continue to elevate the importance of maternal health and just mothers in general and what they're experiencing. The other thing I think is really important is for communities not only to let their voices be heard, but to also work with their state and local legislators. The governor and the General Assembly direct Virginia Medicaid to add additional providers and to make reimbursement rate changes. And so organizing your voices, elevating your voices can bring some of those changes about.
Thank you so much to each of you for what you've been able to share. If anyone has any questions, I see they've positioned some mics here. We have time for just a couple of questions. If you have something specific that you'd like to ask, please visit one of the mics. As they are coming, please give a hand to our panelists. Thank you so much.
Good morning. My name is Monique LaCroix, and I have a supportive in-home agency here in Newport News, Virginia, and a couple of other businesses that's diversified. My question is to the Medicaid DMAS representative. What is it that we can do that are already licensed professionals in the mental health field to assist in this, even if it is for us to do it without money? Because as you know, as a Medicaid provider, sometimes we do things without money, and we get paid, and we understand that it is a delay in pay because we've already been billing Medicaid. So what is it that we can do in our community? Because I'm from this community. I now live in Williamsburg, Virginia, but I have businesses in several locations, and I want to know what we can do and get together with Medicaid, since we're already licensed, we're already certified, we know the process. How can you guys get with us, the legislators, to figure out how we can provide these services? It may be at a lower rate until we get higher, but because we're already billing and we already have money coming in, we can put training through under our umbrella to pull back into this community. So if Medicaid can tell us how we can do that in an easier format, because we know all things are not easy through DMAS, that would be great. So I'll sit down and listen to you.
So I think, and I didn't catch the whole part of the beginning of what organization you said you had, but I did hear mental health professional. So I am not a behavioral health professional or expert, and I do have people within the agency that I could refer you to. But I think the first thing is, as I was mentioning before, is really the collective voice, really partnering with the staff that's in our behavioral health division to really see some of the things, because we have extensive mental health services. So seeing what is in existence already and how you can partner with some of those initiatives that are already going on. If it is that you're asking me about being a mental health provider within Medicaid, then I can certainly talk to you offline about, in terms of exactly what you do and seeing if something that you're providing is something that is already reimbursed by Medicaid. But if it's something that you're asking about having a new benefit, the way the doula benefit came about, then that is a process of organizing your voice, working with your legislators, having the bills, carrying them forth and going through the process to have a new benefit within Medicaid. So different processes depending on exactly what you're looking to do.
Thank you.
Thank you. Any other questions? Burning questions. Oh, yeah.
So thank you. This is a great panel. I'm Gayleen Kanoitan with Celebrate Healthcare. When I talk to people on the ground and we go door to door, doulas are still not known in the community, and we have to do a better job. Is there a reason why doctors can't recommend doulas or educate their patients on what doulas are and what they do? I mean, I see that as being a gap. I think that because doctors are trusted, of course. I know some doctors see it as a threat, but is there a way to change that culture where doctors and nurses can educate their patients on what doulas do?
I'll speak to my experience. I think what I recognize is that just as the community doesn't have a good understanding of what doulas do, like Dr. Bonner said, providers don't have a good understanding of what community doulas do. And so when you don't have a good understanding of it, you really can't speak to it. I also think there's something to be said about relationship. And as a provider, I'm really thinking about who am I working with in community and who do I have a good rapport with in order for me to be able to refer to certain individuals. And the reality is when you don't have that, it's very difficult for you to make that recommendation. I will say, however, that I have seen systems change. Our partnership with Sentara has allowed us to get in front of nurses, providers, all of these others and individuals, and they're all vested in ensuring that clients understand the doula role and getting connected to services. And so some of that starts also with the system of care and being able to take this movement and to talk about it and engage and integrate it into what exists. And when that has happened, it has changed many things, because now you have executives who are saying, hey, we need to change the culture here. And how we're going to do that is through engagement with certified nurse midwives, with doulas. We're going to bring in community partners. And I have seen in the instance of our partnership with Sentara, the entire system shift. and providers shift to provide a different level of care because they recognized that it was important. There was a relationship that was built that allowed it, and then there was a resource that they could use that they trusted that allowed them to engage their clientele. Also, I would say, just on a general level for like the state, I believe that our goal, working with managed care organizations, there are many of them that are here today. We've been putting information out to providers to let them know about the doula benefit, let them know what doulas are and what they do. There are a lot of forums. There are community health workers and others that are going to these providers and talking to them about what this looks like. And so I think that as we continue on, we just have to keep pressing and keep sharing the word and bringing information out there and making sure people are aware of the resource, and also building workforce, because it's nothing like saying that you're going to push the workforce out there and then there's no workforce to refer to. So I think that that's also one other issue that we have to address.
Go ahead. I just want to piggyback on some of the things that Stephanie has said. I think, as I mentioned, the benefit is still pretty new. DMAS hadn't had a new service or a new benefit within the last decade. And so to have this doula benefit is exciting, but is also met with growing pains of anything that's new. And so the first, I would say, year was really building trust within the doula community to try to get doulas to come on board, to understand Medicaid, and just that to build that trust in having community partners work alongside of a state agency. And so overcoming some of those barriers, that was really step one. And then the implementation of making sure that the systems work so that when you submit something, you can get paid. Building a structure within the pay structure of a 14-day pay, so that they don't have to wait 30 days. It's 14-day pay for doulas. So some of that education was like the first wave of education. So the provider education is something that, we've come a long way, but we still have a long way to go. And so working with our providers, now that we've gotten some doulas into the system and working and providing services to our 40,000 pregnant Medicaid members, but also continuing to support the doulas that are there so that they don't burn out, so that the whole world doesn't feel like it's on their shoulders, continuing to support them while also educating the providers. So we're doing things like information services, trying to go to communities. We went out to the Southwest, we're here, trying to reach into Northern Virginia and seeing, what areas we have people going to, like the Eastern Shore, so trying to do lunch and learns and things like that. So that was one level of trust with the doulas, but as you can imagine, there's another kind of overcoming some trust with the providers. Maybe they've had a bad experience or heard of something that happened, and so, just understanding and having, them overcome that. And then the other thing is just even having to dispel some information about how doulas can, I think the word refer, a lot of times doctors might feel like they have to refer, like a medical referral. And what we have is a doula care form that basically they sign. There's no supervision, there's no formal referral, but they do have to sign that. So I think helping to educate about the form and all kinds of things that surround kind of the doula benefit. So thank you for that question.
I just wanted to add one thing about the work that we're doing over the next 5 years, because I'm a scientist and we do research. So one of the things that we're finding with this doula role is all of the pieces that we have talked about here today. And, the lack of respect, the lack of standardization, the certification. And so what we need then is a vision. And so what I say to my colleague at Morgan, her name is Keisha. So I say to Keisha all the time, we've got to get a vision for this doula role, because one thing you mentioned is demand versus the number of people that are out there. So you build a big demand, and then all of a sudden they really are overwhelmed, and then you have another problem. So the vision needs to be one where we're going to try to work together as we move forward, so that we have a big vision for this role, as well as you have the people who are there to fulfill this vision. And so at Morgan, what I'm suggesting that she do is place a lot of emphasis on the community. I'm so excited to be here at the church because, I've belonged to church, taught Sunday school for 40 years and all the 9 yards. But let me say, from an academic center perspective, we often don't treat the community the way it should be treated and value it the way it should be valued. So if we want this word about the doula to get out, we got to work it through our communities. And our churches are a major instrument in that. Our beauty shops, our barber shops, our other major instruments, our Divine Nine, our sororities, our fraternities, other ways in which we should be getting this message out in our community, create the demand. Now, on the other side is the workforce. So how are we going to structure that? You have to structure, we have, right now, we're looking at our communities, the bridges and things being built. And we're saying that we don't have a workforce, everybody going to college and get PhDs, but we have a huge workforce who has value. And so therefore, we have to make this doula role into its value, so that as we build that workforce, you have the demand on the bottom side, but you have that workforce who is now ready to meet that demand.
Thank you so much for that. We'll take one last question. So we'll take two last questions. We'll try to wrap it up really tightly here so we can stay on time. We're standing between you all and break. So we'll take question here, and then we'll close out. Thank you.
Thank you. The pressure. I'm asking on behalf of Destiny Flanagan, who is on your virtual audience. She wanted to know, well, she stated, recently Virginia has passed the doula private insurance coverage bill. How might this change the landscape of birth work and certification?
There's only some pieces I can really talk about in that aspect. I guess the only thing I would say is that as a Black woman, right, when I become pregnant and I have a baby, irregardless of my education, socioeconomic status, access to insurance or anything, I'm more apt to have a poor outcome, right? So we have a lot of women who are on the commercial side who are not Medicaid insured that are unable to access doula services as a result. Mm-hmm. And so with that being said, with the changes in commercial insurance being able to cover doula services, this also ensures that we're able to support women who are outside of that traditional Medicaid bracket as well, which will bring in an additional population of folks who we can serve in hopes that we'll see better outcomes as we continue to go along. So they tend to be a neglected side, similarly to how those who are insured by TRICARE, who may not be able to access doula care and services as well. With that being said, and I think our hesitation was this is very brand new, so there are a lot of things that we have just not been able to work out or think through or talk about, and so I think there may be some concepts that we aren't able to really address today, but I'm sure that the conversations will be at the forefront in the coming year.
And I just echo that. We know that, as Stephanie said, it will open the door for access for another population to receive doula services, because doula services were only covered by Medicaid, and TRICARE does cover Medicaid, but private insurers did not. So that opens access for more women to be able to have doula support. That we do know.
Thank you for that. And our final question.
Hey, good morning. My name is Quatisha Monique, and I am recently a trauma-informed doula. I'm very passionate about silent illness and the bringing awareness to silent illness and how it affects people around the world. So because of that, also creating research as to the importance of new moms needing a doula that's already suffering from silent illnesses because there's a weight that they already have to deal with that they don't understand, and then to now have all of the emotions, all of the weight of a new pregnancy as well. So my question is, I'm doing research with that as well as part of with Cocoa Like Black and everything like that. And my question is, how do you become a part of what you were talking about, Ms. Bonner, with the doula pre-construction, the the preconception doula construct? How do one become a part of that and being able to input value that may be able to help going forward to open up other arenas for, again, bridging the gap between an issue that's not very much tapped into, that needs more awareness, as well as the doula bringing more awareness and bridging that gap together.
Well, let me just take a minute to say what the project is, because I haven't actually had a chance to mention that. And I do have flyers for anybody who's interested in knowing more about it. As was mentioned at the beginning of our program, the Biden administration has invested more than $90 million in maternal health for all the reasons that we've talked about. At Morgan State University, I am the principal investigator of the coordinating center of 16 universities that have been funded around the U.S., and they're located in Alabama, California, Florida, Georgia, Hawaii, Maryland, Mississippi, New York, Ohio, Tennessee, and Texas. And these universities are all funded for 5 years to examine the question that's on the table. Why is it that we have women of color dying at such exorbitant rates? And one of the things, where's the young lady? I don't see, oh, there she is, yeah. One of the things that we know is important is the ground up. That's an approach that we're taking. Now, these are minority serving institutions, HBCUs, so you might ask, why was this all invested to begin with? It's because these schools have not really been in the throes of the research agenda. We have not been able to have the funding, so now we have it. So the question is, what are we going to do and how will we do it differently? One of the things we hope to do is start with the community. We are doing a lot of listening. We are doing a lot of meeting with churches, with barbershops, beauty shops, the Divine Nine, trying to let them see that we want to use a bottom-up approach. The next thing we're doing is this doula piece. And the doula piece for us is research, right? In other words, what is the role of the doula? What is the impact, that word impact that you used at the beginning? How do you use research to, in the long run, be able to give you the numbers that CMS is going to need and anybody else who is going to formalize this funding for them? And so we're saying, as we have looked at what doulas do, we're saying that there is an expanded role in this preconception. So your question of how can you get involved? Come to Morgan. You already at Morgan? Okay, you live in Maryland, all right. And so what we hope to do, though, is online training, because we know we can't mobilize everybody. And like I'm learning, nobody's moving. And by the way, we aren't even going to work either. We want to do it at home. And so what we're doing is online. We're hoping to do at least an online construct around this preconception piece, because that would be new, and doula is already new. So, trying to add things on to what's already out there is a challenge. So we don't know how successful we will be, but this is our vision.
Thank you so much. So as we close out this session, a few of the things that we just want to keep in mind, there's 3 things that always come to mind that when I sit through sessions like this, I'm thinking about how do we educate, engage, and empower. And so we learned about the importance of education. One, not just us learning more about the role of a doula, the assignment, and how it influences the work across the perinatal space, but also being able to educate others on what the doula does so that we all know. So it's like anything else, right? When you heard about something good, whether it was a discount at a local store or a new meal that came out, you tell everybody. You tell everybody, hey, did you know that this was on sale? Did you know that so-and-so got this food? I went to this place called George's. Did y'all know they have real good cheesesteak rolls? I share. That's the same way we have to do about this work as it relates to doula. When it comes to engagement, What does access look like? How are we building broader spaces for access so that people can have doulas? And then what are we doing to engage ourselves in the activity of, again, sharing more information, building relationships with the persons that are in the community, those trusted partners? And then the last thing is empower. So with Cocoa Life, one of the things we always say is we are building a community, we operate off of a community empowered model of care. So the more trusted the community feels, whether it's through faith-based organizations, the Divine Nine, other channels, then that's also what's going to help. So if I come in because I've just had this relationship in these three components and I ask my physician, do you know any doulas? Guess what? They're going to start to learn more about what doulas do. They're going to want more, like, because I'm getting asked this question, and we all want to make sure that we're able to offer that. So again, thank you so much. A great rest of the afternoon for us, and we're going to take this time to take break. All right, we're going to take this time to take break. Please give a hand to the panelists here. Thank you all so much.
I have enough of those. They're on my desk. I should have brought them up here, but I just wanted people to, yeah, I will be sure you all have one. This is a great, I'm right at this table where the yellow, yeah. This is $50 million, and unfortunately, many of our HBCUs didn't apply. And so you would recognize the names. They're the minority serving, but they're Hispanic, and Hispanic birth is better than white. So they don't really need this, but we could not get them to the table. I was so disappointed. It was speaking of low hanging, it was so low hanging. But you see, they do the work. It's so hard for us to
Bravo, bravo, bravo. And I'm so sorry about the slides.
yeah.
I was like, yeah.
Not a
So
problem.
I'm sorry, but you all handled it.
did a great job.
I came out of the press and I was like, oh, okay. They're just going with it.
Just go
I
with it.
love it.
That's
I
right.
love
You
it.
have
I
to go
love
with
it.
it.
I was like, well, you all were going with it so well that there's a gentleman who wants to interview you if you all feel okay to share your experiences about what you've experienced personally with the healthcare system and things like that. If that's something that you want to share. Okay. Absolutely. Do you have someone else who has a? Yes, we can get a pic. Hold on, let's get a picture.
Oh,
We don't want $50 million to disappear.
It will not. Trust me.
You got me? Okay.
Oh, am I coming back?
I was gonna say, get in front of the table.
Yeah.
And then stand on either side of
You're broke. Can't take you anywhere, Natasha.
Okay, so let's stand on the either side of the Sentara side.
Where is that? 2 and 2.
Right
Behind you.
Oh,
It's on the tablecloth. So 2 and 2.
One more time. There we go. Okay, you ready?
Can I touch?
Yeah.
Here first, please. One,
Love that.
two,
Thank you.
and three. One more. Okay.
All right.
Let me grab one.
Oh.
Oh, it's waving.
All right.
Oh, I have got to. I have got to
Get this back to you.
like 2 minutes away.
Oh,
I mean, not far at all.
oh, goodness.
Thank you so much. This was awesome. Y'all are amazing.
Yeah, each and every one.
How you doing? I collect
like my short piece.
Yeah, so we're
Okay.
on the State Innovation Agreement.
So, will you be willing to share your
Yes,
hello.
where you're here in this area? Are you coming with
Absolutely.
Inside to get it done.
Okay, so I want
Yeah,
one of
let me
these in
just
your
go
car.
down to my.
Can we take
Oh,
Natasha?
it's
She wants another
wonderful,
picture.
wonderful. This is great. Oh, absolutely. Amen. Uh-huh. And then drop. Along. Amen. Amen.
I know. One more picture.
Amen.
Oh, one more picture.
Well,
Rehearsing. Okay. You got Sentara? Yes. Okay. That's good.
I think I should have mine too.
Okay.
Okay, and somebody needs to send me.
I can
Oh,
send
you can send it to me. Okay, good. 'Cause I don't have. I want you to send me the picture if you don't mind.
Oh, yeah.
Yvonne.bronner@morgan.edu. Okay.
Yeah, I know. Thanks, Dr. B.
I know I should have a card. I don't.
Just write it.
Yeah, let me do that.
I don't know who this one is. I think I have one too. Thank you. Okay. All right. I saw Dr. Stevens take one. That was like my desire.
Okay, so somebody can send me, and then I want to get you copies
went to a
of my
meeting. Oh, yes.
handout.
Here, I'm gonna take
You know.
Oh, you got it. Okay.
Yeah, I'll send you the ones I have.
Okay, good. So let me go down and get you copies of the handout so that you can have a description of this
I
project.
snatched this one, didn't I?
Oh, you got that one.
This is Heather's thing that's happening this weekend. No, May 4th, where she's doing the Kennedy Angel Ball. I didn't bring this, but I'm just telling you. And then, because I saw you like ask me some questions, and then they're doing their filming with Aftershock. And I think Amber's presenting. Maybe somebody else. So that's what that is.
Okay, so we have about 6 minutes before we reconvene. Please go over and grab some snacks over on the table, chips, cookies, water, juice, whatever you need, and then we'll go ahead and get started with our next panel on preconception care. Okay, good morning again, everyone. We're going to go ahead and get started. I hope you had a chance to get some snacks, goodies to give you energy because we're about to dive into yet another great panel. And speaking of that, let's just give our panelists from the first panel another round of applause. So we talked about doula access and services, how people get connected to doulas, perhaps they're referred. As Alexia so adequately put it, it's word of mouth. You tell somebody about something, and as Dr. Brano said, we build it into community. That's what we want to see as we continue to move through this space. The other thing I also want to let you all know is tomorrow we're going to have a specific section on a call to action. And I want you to think about, as you hear the speakers, perhaps you heard something this morning or through this afternoon or tomorrow at the prayer breakfast, I want you to think about the one thing that you are going to do to take an action in this space. If you're an advocate, just decide that I'm going to be a bigger advocate, and specifically, what does that look like? Challenge yourself. And I say that not only to you, but I do it to myself as well, because the women and the babies in this space, they deserve it. We cannot be just business as usual. We have got to lean in and say, how are we going to do something different? You know what the definition of insanity is. So let's try to do something different. What you decide to do, your personal action, if you try it and it doesn't get the outcome you expected, that's okay. Try it again. Do something else. But whatever you do, every morning, get up and say, the women and the people that we serve, that I know, that I heard about, that I read about, that I saw on TV, they deserve it. This is what community is about. It's not just doing one thing, and it's not just saying, oh, it's someone else's issue. It's our collective responsibility. So just keep that in mind, and I'll be interested to hear any volunteers tomorrow on their call to action. So our next panel I'm excited to see is about preconception care. I think you heard in the first panel, sometimes people are aware and they plan their families. And what does that look like? Managing chronic conditions. If you are not the weight that you want to be and you say, okay, I want to lose a couple of pounds before I have my baby or get my body as physically prepared as possible, you may want to start an exercise program or start changing the way you eat. If you already know that you have high blood pressure, talking with your physician about what do I need to do to manage that chronic condition prior to conception. Or if you're not planning, but you know that you have diabetes, or you have high blood pressure, or you have other conditions, and you suddenly find that you are now pregnant, working with your physician to say, yes, I want the health of my baby to be good, and I want a good maternal outcome, but I also want to make sure that I'm taking care of myself. And here's a statistic that I did not know of before I went to the Black Maternal Health Summit in Enon. And that is that a lot of times when we think about maternal mortality, we think about it in the process of giving birth or while someone is giving birth. But actually, more deaths occur after they've given birth, in that first 6 months to a year after. So that's also managing chronic conditions. So please listen to what the panelists have to say and lean into that space as well. And now it's my pleasure to introduce Sharon Graham, who is the Regional Administrator For the CMS Philadelphia office, Sharon is the Regional Administrator for Local Engagement and the Administration of Office of Program Operations. As the Regional Administrator, Sharon leads and coordinates external engagement efforts around CMS programs throughout the Mid-Atlantic states. She is the national lead for the agency's Medicare open enrollment, the Marketplace, the No Surprises Act, and the flu vaccination campaigns. She also provides administrative and operational support to all employees in CMS Philadelphia, promoting cohesion and collaboration, there's that word again, throughout the regional office. Please join me in welcoming Sharon Graham.
Thank you. Okay, there's the button. Good morning, everyone. I'm so excited to facilitate this next panel of superstars in the maternal health space. And I'll call each of them up, and we are joined online by a third person. And at that point, we'll kick off our panel. So first, I'm welcoming to the stage Dr. Amber Price, who is the Division President at Sentara Williamsburg Regional Medical Center. Sorry. Followed by Megan Buchholz, who is the Community Impact Director for Maternal Health at the local Hampton Roads American Heart Association. And then we're joined online by Galissa Jones with the Philadelphia Department of Public Health. Specifically, she is the Health Equity and Community Outreach Coordinator. I think you can see. You can all see her on the screen? Okay, good. Couldn't tell. All right, so we'll facilitate our panel discussion from here, and then similar to the last panel, we'll also take questions then at the end. What I first would like to do, though, is in your particular maternal health packet for today are detailed bios of the individuals on our panel, and they bring not only years and years of experience, but lots of credentials as well. I'd like to take the opportunity for each of our panelists, though, to introduce themselves to you and also explain how they came to the maternal health space and their experience and their passion that they bring to us here today, not only really around preconception care, but just general maternal health and infant mortality generally. So I'll start with Dr. Price, then with Megan, and I'll go online to Galissa. There we go.
There you go. Thank you. Well, for those of you who don't know me, I'm Amber Price, and I actually started as a doula. I was a doula and a Red Cross volunteer. I was a military spouse, really got involved in maternal health overseas, working with women who didn't have any support at all. Eventually became a nurse, became a certified nurse midwife. I am originally from Holland, where there's a very different birth culture and where women have a different standing in society as well, and was really drawn to rural health and global birth. I have a postmaster's degree in global women's health, and then started traveling. I worked in New Zealand, I worked in 9 other countries attending births. I started in home birth, I started in rural birth. That was my passion. Eventually, over the years, I moved into the more administrative side. I am now the only certified nurse midwife in the nation who is also a hospital CEO who leads health systems. For Sentara, I function as the executive sponsor of the Women's Health High Performance Team and also the Women's Employee Resource Group, because empowering women is a big part of this discussion, and it's a pleasure to be here today. Thank you.
Good morning. Thank you so much for having me. My name is Megan Buchholz. I am a registered nurse of over 25 years now. I can't believe I'm saying that. I don't feel that old. But I started my career at the bedside actually before I graduated from college. I was a nurse extern in the maternal health space and got hired on. Worked at the bedside for about 12 years and then started dipping my toe into the leadership space. And I found that I love taking care of the people who are taking care of the patients and really advocating for change that was happening at the bedside. Since that time, I have really found a passion back in the community, starting some community work in conjunction with some community health workers alongside the hospital, and really ignited my passion for working in the community, and really realizing that there is work that's done at the bedside, but most of these women and birthing people, what happens to them happens preconception, pregnancy, and in the postpartum space. And so it's really important that we focus on that. So my work now with the American Heart Association, who is celebrating 100 years this year, by the way, it's our birthday, we have received a grant for the Hampton Roads region from the CVS Health Foundation to specifically join this conversation on maternal health and really focus on taking care of women in our community and try and identify some best practices. So, as you know, the leading cause of maternal mortality is related to heart disease, hypertension, preeclampsia, all of those cardiovascular issues. And so my work specifically now is focused in that area.
Thank you, and I'll turn it over to Galissa Jones to introduce herself as well. Galissa. Can you hear us, Galissa? Can you provide a brief introduction, Galissa? Can she hear? Checking with our ED folks. Galissa, are you able to hear us to provide a brief introduction?
Hi, everyone. My name is Jaleesa Jones. I am the Health Equity and Community Outreach Coordinator for the Maternal, Child, and Family Health Division of the Philadelphia Department of Public Health. And I am very excited to be here with you all. Sorry, there's a delay on my end.
All right, thank you. So I'd like to start off with our questions actually hearkening back to something that you just said, Dr. Price, with your experience internationally. And if you could...
Birth educator, just recently got certified. I am a certified lactation counselor. I'm also a trained birth and postpartum doula. I have worked in public health, specifically for the Maternal, Child, Family Health Division for the last 14 years. So I've worn many hats and very passionate about this work.
Thank you, Galissa. All right, so I'd like to start off our first question for the panel with Dr. Price, and hearkening back to what you said in your introduction about your experience and how the Holland system is so very different. And so if you could level set us first and draw some parallels in the experiences that women in other countries have with their maternal health versus what we're experiencing right now in the United States.
Well, I think it's a very relevant question. It's an important question. And what I've learned working everywhere is that birth is birth is birth. This is essentially should be a normal, natural process that has been perfected over many thousands of years. So innately, birth itself, should be very similar, but that's not what we're seeing. We're seeing that there are very different personal experiences. We're seeing women are treated very differently in different areas of this planet. And then what we're also seeing is completely different outcomes when people on paper should actually be exactly the same. So what we know is that there are major cultural components to that. I often say one of those things that stood out to me in the U.S. is that it's very difficult for women to find their voice. And it's not just your voice in healthcare. I know very few women who are comfortable sending a steak back in a restaurant. Most women I know are like, it's okay, it's not what I ordered, but I'm going to just keep it that way. And that is a bit at the root of the issues that we see, not just in the U.S., but globally. There are still countries where women are beaten while they have their baby, right? Almost 300,000 women died last year from birth and pregnancy-related conditions globally. So compared to that, you would say to yourself, well, it's just, then the U.S. is a drop in the bucket, right? It's a tiny bit. But our bar should be set at 0. Our bar should be set at 0 globally. No woman anywhere deserves to die from a preventable condition. Medicine has evolved to the point that we can really, if we have a great relationship with that person who has access to that care, can help with most of those preventable conditions. There will always remain some things that we may not be able to prevent, but as a rule, we know that what's happening in the U.S. is preventable. So what I tell people is, Don't start finding your voice in the labor and delivery room. That is not the time to start having great conversations about what's important to you or how you should advocate for yourself. That's something that we should be teaching women from the time they are in middle school. Right? Participating in society, speaking up for yourself, finding your resources, and normalizing that is going to go a long way in helping eradicate some of these issues where communication and being heard is part of the problem.
And I think that what we learned earlier is doulas can really help in that space. When you're in the middle of a birthing process, you need that voice.
Yeah, doulas can be extremely helpful in that because they sometimes what helps with a doula is that they help you identify the problem or the issue, and they can encourage you to speak up or encourage you to talk to the right person. The other component is that we don't always speak the language of the people who take care of us. You know, I often hear that people are a little bit afraid of the healthcare system, have had negative experiences, or have felt belittled when they did bring something up. And they don't always know how to have that conversation, particularly without a whole lot of fear in that conversation. So I think where doulas work very well is in helping people have those conversations, practicing that, giving them the words, giving them the information. It helps them have really meaningful conversations with the people who they need to listen to them.
I want to call on Galissa here. Galissa, you just heard Dr. Price speak about some of the differences that we have globally across the birthing experience, when perhaps that should not be, not even perhaps, that shouldn't be the case. And you're in Philadelphia, and we're down here in Hampton Roads. And so I'm wondering what sort of unique challenges that you're seeing experienced by women of color in Philadelphia, and then if we can contrast, or if we're hearing some of the same things in this particular area too, just wondering if we can explore that universal experience, and that might give us a foundation for sort of trying really to address some of those issues, those situations that women face. And Galissa, let me know that there's a bit of a delay in the response, so we'll give it a few beats.
Women of color face unique challenges when it comes to preconception care in Philadelphia, as in many other parts of the United States. These challenges can be attributed to a combination of systemic inequalities, socioeconomic factors, and cultural barriers. Some of the specific challenges include access to quality health care. Women of color face barriers to accessing quality healthcare services. This can be due to factors such as lack of insurance, parental approval of services, limited availability of healthcare providers in underserved communities, and transportation issues. Additionally, economic disparities can impact a woman's ability to access preconception care. Women of color are more likely to be living in low-income households, which can limit their access to services and resources, or being able to take time off from work, or even afford child care to even attend appointments for themselves. Cultural and language barriers. Cultural beliefs and practices can influence a woman's perceptions and attitudes towards preconception care. Language barriers can also pose challenges in communicating with healthcare providers and understanding medical information, not just limited to linguistic barriers, but cultural language. Also, discrimination and bias. Women of color may experience discrimination and bias within the healthcare system, which can impact the quality of care they receive. This can include racial and ethnic disparities in treatment recommendation, access to services, and overall patient-provider interactions. Just believing someone is actually experiencing pain or discomfort or overreacting. Lack of awareness and education. There may be limited awareness and education about the importance of preconception care with communities of color. This can result in missed opportunities for early intervention and preventative care. We have to do better at equipping the youth with the tools to access preventative education and care without shame or fear of exposing them to inappropriate topics. In today's society, they are already accessing or taking part in so much way too soon because the conversations are happening too late. Also, environmental and community factors. Environmental factors such as exposure to pollutants inside and outside your residence and lack of access to healthy foods and safe spaces for physical activity can also impact preconceptional health outcomes for women of color. Redlining and systemic and racist practices that have prevented many of the access to safe environments still exist today. Addressing these challenges requires a multifaceted approach that involves improving access to healthcare services, addressing socioeconomic disparities, promoting culturally competent care, and increasing awareness and education about the importance of preconception care within communities of color. Community-based initiatives, policy changes, and targeted interventions are essential steps towards addressing these disparities and improving preconception care outcomes for women of color in Philadelphia and beyond.
Thank you, Calissa. Go ahead. Yeah, definitely thoughts here.
So I just wanted to add to that. Thank you, Galissa, for all of that insight. And we know that the Eastern Shore is the highest rate of maternal mortality in our state. We have had several hospitals that have closed maternity services, so we absolutely have some maternity care deserts here just within our region. And we have a varied mix here in Hampton Roads of rural communities and urban areas, which also contributes to disparities, to inequities, to those social determinants of health that certainly impact our patient population and the clients that we serve. So it's really important that we understand. We also have a very large military community, which brings a whole nother element of culture. So all of those things certainly contribute to the space that we're working with here in Hampton Roads.
Thank you. So actually, Megan, I want to follow up on something too. From the American Heart Association perspective, and you've been working on this, and thank goodness for the grant where you can even delve into it more deeply. Can you describe some of what people should be looking for, whether that be in the preconception space or even during prenatal care, that they should be looking for signs and symptoms and challenges that they can then address head on to have a better maternal experience?
Absolutely. So I've made some notes because I don't want to miss anything, but I think it's really important that we start, and I'm glad that we have a person from the school board here, because I think it's really important that we start this conversation early. We need to be talking to our teens, both boys and girls, about what a healthy lifestyle looks like. And what pregnancy looks like, what to be looking for. It's important for every person in the room to know what your body does, how it feels, what your normal is, and to know your numbers, know your cholesterol, know your A1C, know your blood pressure baseline before you even consider getting pregnant. I think it's also important to, as was discussed before, to be healthy before you get pregnant. If you need to lose weight, get moving, eat a little bit healthier, make some small changes, stop vaping, stop smoking. All of those things contribute to an unhealthy pregnancy and an unhealthy outcome. I also think it's important to know what resources are in your area. So where are the doulas? How do I find a doula? What does my insurance company or Medicaid provide? Many of them have care managers that can assist you in the pregnancy and beyond. So what is that provision of care? And how do I access that? And I also think it's important to surround this person, this birthing person, with the men and women that will be supporting them in their journey and make sure that they're well educated. Men, I'm glad that was brought up on the last panel, that men are such an important piece of this because they are our fathers, our brothers, our uncles that will be surrounding us as we take this journey and need to understand what the implications are.
Would you like to add anything, Dr. Price?
No, I think we'll pass it on to the next person.
Want to make sure I didn't miss the opportunity. So when we talk about preconception care, I haven't had children. Now, my children are 23 and 21 years old. This was definitely not a concept that I was familiar with. But as I was researching it, this is the foundation. Just like with anything else, you need to really start with a healthy foundation. And I think that Dr. Bronner had mentioned it earlier about having even the idea of a preconception doula to get people really used to the idea, to know your numbers, as you said, and to know, again, also the team that's there to support you and the community and then the resources. And so I feel like that really speaks to overall the relationships that we need to build across our whole maternal health experience. And so first I'll start with you, Dr. Price. If you can explain to us the importance of those relationships to the overall birthing experience, whether that be through preconception care and all the way through the postpartum process.
Yeah, we know that having a relationship with the person who manages your health is important. And it becomes most important when you have a crisis of some sort and you need to get a hold of them and need to be heard in that sense, right? But I want to remind everybody that a lot of people have great relationships with the people who end up delivering their baby who don't have good outcomes. So that relationship on its own doesn't necessarily mean, right, that that is then automatically going to be, the birth that you were envisioning or something that was important to you. In fact, if you look at the Listening to Women study, which has been a long-standing, ongoing study that tells us, how women are engaging in their care, how happy they are with their providers, we know that most women in our country are actually delivered by the person who took care of them, but it doesn't correlate to positive outcomes. In the end, what we know is that access, right, wraparound care, all of the other components that safeguard you need to all be there, and you cannot rely on your relationship with that one person. What we need to get to is a place where if you pick up the phone and call, somebody believes you. And so a lot of the work that we're doing in Sentara is way more than just that one contact or that one connection. We may not be with you when you're on vacation somewhere and end up in an emergency room with an emergency. It needs to be a much bigger discussion of how do you create safety nets? How do you create positive cultures? How do you create intentional cultures? How do we educate those people who may not know a whole lot about pregnancy and may miss something? Right, Megan and I both served on the Go Red for Women board this year for cardiology. We know that in Sentara, and Dr. Asher spoke about that this morning, 73% of the adverse outcomes we see are directly related to a cardiac issue. So how are we as a system connecting with women early in pregnancy, identifying those issues, getting you to the right people who can manage that cardiac condition, get you through a safe birth, and then get you heard for that whole next year after you have your baby? So that when you call 2 weeks after you have your baby and say, I don't feel well, and you get dismissed by whoever you're talking to, then all of that didn't help much. So that really understanding what we need to do for essentially the 2 years that we're talking about, that right before you get pregnant, the entire pregnancy, the moment of birth, which if you think about it, you're in the actual hospital only about 3 days of that. Right? That is why, and I really appreciate Melissa bringing that up on the last panel, the idea of this is happening in the hospital at the time of birth. That is something we need to start getting our heads away from. The issues that are happening in that 2-year time period, and we need to make sure that we're touching every part of that 2-year period. Physicians who come to the hospital, providers who come to the hospital often don't work for the hospital. They are independent providers in the community. And you are the one who's building that relationship with that provider and then coming into the hospital with them. That's where that relationship becomes really important, right? But they are only one part of the problem and of the system. So what I think I often see is that women are like, but my doctor knows me and I've got a great relationship. That is not enough. We need to get those touch points everywhere along the way so you're safeguarded even if you don't know that person. You want to know that when you come into an emergency room, that doctor knows the difference between preeclampsia and high blood pressure. That has nothing to do with pregnancy. And that's what we're heavily focused on, safeguarding you all the way around.
Thank you so much for that, because that is so important. And I think it's also important to note that an OB provider, provides care through that postpartum period, which could be 6 to 12 weeks postpartum, but then you have that rest of the year, right? So creating a warm handoff between the OB provider, including the patient in that handoff, and making sure that they have access to a cardiac physician or a primary care physician to continue that conversation, understanding that this pregnancy will continue to have effects for that year and beyond, and the chance of heart disease or hypertension issues can continue to be an issue through that first year. And so I think it's important to engage not only the OBGYNs in our communities, but also the cardiac providers, the primary care providers, and the people that work for them in understanding what to look for and how to help those patients.
And if you keep the microphone a second, I'm just wondering then, and then we'll work backwards, how do you educate the family, both the expectant mom and that support team, that this isn't a one-stop shop, right? This is really something that starts as early as preconception care, but carries through, and there will be this warm handoff, but it needs to continue for these reasons. How do you go about building that?
I think it's important not only to educate the patient and their family, but also to make sure that doulas are educated in how to continue to advocate through that postpartum period, and that it's not always going to be the OBGYN that you encourage your patient to call. Those community health workers, those home visiting agencies, those managed care organizations that are providing that follow-up care to continue to assist that patient in advocating for getting what they need and to not stop asking.
And Sentara in this space is doing a lot.
Yeah, we are doing a lot. And, this is now that we really kind of have identified that there's a 2-year time period, what we're doing is actually providing navigators. So from the moment you get pregnant or start thinking about getting pregnant, you have a navigator to connect with that will connect you with what you need during your pregnancy. For some women, that is access to childbirth education, which in many instances is not free. It's very difficult nowadays to find the right education at not an exorbitant cost. But we make sure that is free, so that people have access to that, regardless of if you're having your baby with us or not. Really working on education around what do you do when you take that baby home. Many women are so focused on kind of the birth experience, kind of that photo moment, that the reality that hits you, right, when you're having that baby and then go home is absolutely overwhelming. The knowledge that you need to build a support system to take care of you, that this is really difficult. That's where we are focused, right? Is somebody holding your hand along the way. What do you do when you need specialty formula? What do you do if your baby ends up in the hospital unexpectedly? All these things that throw off that image that you had of yourself having your baby. And then holding your hand for that year postpartum, making sure you have access to what you need. We do that from our hospital side, but also from our health plan side, our Medicaid plan side, and then we ensure that it's paid for. So that's a whole nother issue, right? If you don't have a way to pay for your mental health issues or for breastfeeding support or that breast pump, then we're making it even harder, for you to have a smooth sailing or really a toolbox that's at your disposal after you have your baby. So that's how we're thinking about it. And that's what we've built over the past few years to make sure that we don't just say all that matters is those 3 days in the hospital. It's that entire 2 years, and we are here to make sure that we connect with you before, during, and after.
And you're already seeing the results, I believe, too, as Sentara with that approach.
Yes, we're seeing significant results, and the most important thing is that what we're seeing in some of the new things that are completely outside the box innovative. One of those is a practice that we built in our Careplex hospital a year ago. It is a practice of independent certified nurse midwives. There's no physician in that practice. It is a safe space with certified nurse midwives who look like our community, who think like our community, who were recently featured in a really important article by Pulitzer called I Just Don't Want to Die, and show how that care is different. And I think a lot of our panelists today have done a great job talking about that. If you are being cared for by somebody who understands you, who understands your culture, who looks like you, where you can feel free to speak, where you can feel free to tell people what's hard and difficult for you, we're going to see very different outcomes. And that is what we've seen in that first year of that practice alone. And it underscores that when you think outside the box and when you're listening to your community and building the programs they're asking for, you're going to see the right results at the end of that.
Something you said earlier reminded me of my own child being born 23 years ago. What we all do, hopefully you have a family member come to your house. My mom came, she left after 3 or 4 days. And I remember looking at my daughter and going, now what do I do with you? Because nobody told you what to do. She was just laying there in the pack and play, pretty harmless. But there's a lot that builds up there because you just aren't prepared. So it's so great to hear that we are now moving into educating people that there's a year at least there for people. And I want to go back to Galissa for a second because I know with Galissa being in Philadelphia, I'm from Philadelphia too, that there is, and you referenced this, Dr. Price, community that supports the birthing process. And Philadelphia has a lot of really great programs, some of which are even sponsored by PDPH around maternal health that people can find in the community. And I wonder if you could speak to a few of those programs, Galissa, that people can find in Philadelphia.
So first, I would like to say visit PhillyLovesFamilies.com to learn a little bit more about the initiatives. But in my organization, we partner with both provider and community. We have many coalitions, and I want to mention two. The first is the OVA, which is Organizing Voices for Action. They are a community action team formed to carry out recommendations that come from the Philadelphia Maternal Mortality Review Committee, or the MMRC. This coalition works with community stakeholders from hospitals and community organizations to train providers in implicit bias, whose work groups include early warning signs initiatives, which educates providers and community members on the warning signs that can help get them early care to hopefully prevent adverse maternal outcomes. Also, a collaborative effort with birthing hospitals related to cardiology, an initiative that focuses on intimate partner violence. And the second coalition is the CAN, or the Community Action Network, that comes out of the Healthy Start program, but it is a collaboration of stakeholders in a community that has work groups where providers, organizations, and lived experience experts work together to discuss issues and initiatives to address these issues. There is centering for lived experience experts on the topics at hand. So being a community member is one thing, and then I love that this has given opportunity for folks to see duality and to humanize the data. So being able to be a community member, working in the community and having experienced these things often happens. But when you're at the table and there's someone who says, like, you know, you get to meet the doulas, the mothers, the pediatricians, the birthing families, the birthing folks, OBGYN social workers doing this work, but also the families who have been served and are being served. This works by creating opportunities for collaborative conversations where everyone's input is valued and heard, and there is opportunities to hear the fuller picture of the problem, and also opportunities to create more impactful initiatives to find solutions, or at minimum protective factors. Some of the work that has come out of here is the Philly Joy Bank, which is a guaranteed income pilot that is in the works, that will hopefully be launching around Mother's Day. There's also a lot of different work groups that we've done in partner with a lot of our stakeholders, talking about father support, mental health. There's also a peer support program called what is it? Newborn and Neighbors. And so where you have individuals who are parents themselves, who are trained and then become peer supporters for either pregnant or postpartum families, which is very impactful, because it's one thing to talk to a provider, but it's another thing to feel supported and seeing a community that's being built. And then also, one way that we are educating the community is we also have something called the Family Health Academy, where Philadelphia based, or just providers in general, can get trained on different topics that are health related, but through a kind of implicit bias, or giving them training that helps them to look beyond the data and to kind of humanize and help make sure that it's culturally competent care.
Thank you. And you brought up a topic which I would like to address here around implicit
one more
bias, too.
thing, that the way that we help families advocate for themselves is by equipping them with information about what type of care to expect, and then also giving them opportunity to have those tools to kind of have conversations, to give them the education, and to equip them with just the confidence, and also equipping the community organizations and providers with better care. I think that's also something that needs to be noted. In order for the families to feel supported and to advocate for things, they have to know that it's an option to get better care.
Thank you. And you brought up a topic which I want to explore a little bit around implicit bias and the structural racism that surrounds maternal health care. And then starting with you, Megan, you've been working in this space for a long time. Have you seen some positive changes in that direction that we can improve?
So absolutely, I've seen lots of change, and I will just say I have been a white bedside nurse for many years and a white hospital administrator. And so leaning into this conversation has definitely taken me out of my element, because I do not understand. I am challenged with attempting to understand. And so having those really transparent conversations, I think, is really, really important. Help me understand what you experience. Help me understand what I say that may not feel good to you. And really building relationships both with staff and with patients around that conversation. So I think that one of the biggest changes that I've seen in the 25 years is that we are having conversations about it. We are talking about it. We have seen the beginnings of implicit bias training. We have seen more attention brought to social determinants of health and disparities in our community. We have had the intentional addition of doulas, specifically for women of color, which I think it's such an amazing thing, because it used to be you couldn't get a doula unless you could pay for a doula. And so now more and more women are able to access doula care, and I think we need to continue the work. There's absolutely more work to be done, specifically around transparent conversations. And implicit bias training, we've seen some work in our government, our state governments around mandating implicit bias training, but we need to talk about what does that look like. It doesn't just need to be a webinar where people are clicking the boxes to do their implicit bias training, but how does it impact me? How does it change my practice? How does it encourage me to connect with my patient? So we absolutely need to do more work in that space, but I think we have a good start.
It's experiential, right? Not on a webinar, like your bedside experience too. And I know that from a training perspective also, Sentara has done a lot of work around implicit bias training. If you'd like to speak to that, Dr. Price.
Yeah, I mean, we started in 2018 and 2019 with implicit bias training for our providers who are on our women's health high performance teams, which encompasses providers from across our system. But I think I'm preaching in the choir here when I say that one class does not change somebody from being biased. It is part of what you need to do. And I have a responsibility for, 15,000 births a year to build something around that safeguards people in that space, where, even if there's somebody on that team who may not be listening. I cannot be in every room, right? We can have conversations about it. We can have champions everywhere. We can build in the education. But where we're actually working now is that we now have a specific maternal health database that we've built in our system. So I can now go in and actually pull everything that's happening very specific to maternal health, right? That before we had to kind of dig for that, but to be able to quickly see, what's happening in our obstetric population. Where are these, cardiac issues emerging? Were those people in some sort of prenatal care that we as a system had control over? Did they move here from, Texas and they just rolled in, to the emergency room? Or was this something where we had a touch point along the way? If we have the opportunity for touch points, where do we put them? How do you connect somebody to the right care at the right time? Not every hospital is a massive academic medical center. We've talked about care deserts. The definition of a care desert is that it's 30 minutes to drive to a labor and delivery unit. So think about the state of Virginia alone. How many areas there are where there's not that care in 30 minutes? So how do we as a system and as a health plan start working with every FQHC, every area where we can, immerse ourselves to get these touch points going? One of the things that we realize is, because we can't be in the room and we can't really change who people are by nature, is that there are other things we can do to build safeguards for women of color and women who are at higher risk for maternal mortality. We know, based on our own data, and which is very similar to the state data and the national data in relation to what the root causes are, that there are 4 major identifiers, 4 things that set somebody up to be at high risk for maternal mortality. We know that women of color are 2 to 3 times more likely proportionally, right, to be affected by something that drives ultimately to maternal mortality. So that is one of those. Being a Medicaid patient, just being a Medicaid patient, regardless of your ethnic background, is enough for you to be at higher risk for maternal mortality. Having any history of substance use disorder and any history of a mental health diagnosis. Those are triggers. And so what we are doing now is within our system, our computer systems and our databases, we are building triggers as to what puts somebody at really high risk for maternal mortality very, very early on. And we're taking away the conversations, you know, that can be sometimes really challenging for people who are not comfortable talking about this, and we get very defensive when we say, hey, you may not be listening to this particular patient base. It doesn't go real well in my experience. You know, people are very defensive. People don't believe that they're biased. And so it's very difficult to have a conversation and change someone and then have an immediate downstream impact. We need to build those safeguards in a different way. So what we will do, and we're well along this pathway, is to build this within our system so that every patient has a safeguard, somebody who goes, aha, this patient is at higher risk. I know we've said it before today, your socioeconomic background doesn't make any difference when you're a Black woman. You're at just as high risk regardless of what your background is. And we want our team members to immediately understand that that woman in that bed is at higher risk just because she's Black. So we're calling it an acuity scale. It'll, you know, as your data populates when you come in as a patient, because again, you're only with us 2 or 3 days. We didn't know you before you walked in the door. You were with your physician within the hospital itself. Now it'll populate and it'll say this patient has a risk scale of 2 or whatever that is. That alerts people on the team to stop and slow down and go, okay, somebody with this acuity scale of 2 or 3 needs one-on-one nursing care, because we've identified that this person is at a higher risk of an adverse outcome, even if she's stone cold normal when she comes in, even when we didn't identify any health issues. Creating that awareness that we need to slow down and pay attention, listen more closely, be aware, that's where we're headed. And when you build that level of infrastructure around every patient who walks in the door and taking away the difficult conversations and really focusing on the fact that this is a high-risk patient, that's how we will start to move the needle. We're having these conversations with our physicians. This is a standing agenda item on our high-performance teams. Our physicians are very vested in making sure that all of our patients have a phenomenal outcome. I've never met a doctor who didn't think that was a good idea. So intent is there, right? Everyone wants a great outcome. But the reality is that, you know, it is happening. And we as a system need to acknowledge it, work with our physicians who then are champions within their own organizations and make sure that everybody understands this. That's what we're doing.
And you can use the data to do that. Yeah.
Well, you start with data, because I will tell you that when you go to a physician and say, hey, we have maternal mortality, like, I don't know that that's really an issue for us, right? If it didn't happen to you personally as a physician, sometimes it's hard to believe that it's happening to your peers. And so we need to break through that with great hard data and go, here's where it's happening, right? This is what's happening in the hospital. Here's where it's happening in community. And so that we have a duty to the community too. It's not just what happens in the hospital. We're responsible for the health of our community. That's the commitment we've made as a system. And that means that we need to put money into the community. We need to build things that help build that infrastructure outside of the hospital. That 80% is funded through grant funding, through Sentara Cares. And last year, Sentara put more than $260 million into community, because that is where healthcare happens. And we're seeing that's the same thing happen in the maternal health space.
And I go to Galissa here online. Galissa, what is, from an implicit bias standpoint, what is PDPH in the community doing in Philadelphia to address that for the providers and also for the birthing families?
I'm sorry, could you say it again?
As it relates to implicit bias, I'm sorry if not speaking loud enough, what is the PDPH and others in the Philadelphia community doing to train and address implicit bias?
So as I mentioned in my previous response, we have a lot of collaborations and coalitions that partner with providers and community stakeholders. We've identified that collaborative work is more effective and impactful than if we were to complete this work in silos. And so trying to reach across the aisle and establishing committees, or being more strategic in how we are addressing problems, because we're all addressing the same problems from the same communities and oftentimes the same community members, but at different levels. And so if we work collaboratively to share our data or have conversations and identify the problems, we can impactfully and strategically address it. So with implicit bias is also bringing the community members to the table to have these conversations. so that we're not just looking at data, but we have the anecdotal stories, we have the faces to some of these experiences that can kind of humanize it. And I think it's really important that, I often say, and see within our work, lived experience experts are centered. And it's so important because you can look at a number, but you don't know the story. So we can make assumptions about what would be the best solution, but sometimes we're missing lurker factors or things that aren't seen within that data. So when you have conversations with families in the community and ask them, why didn't you come to these appointments, or the things that providers have these preconceived thoughts on, like, these families are resistant to care, but it could mean that they just don't have transportation, or maybe they are caregiving for other individuals, and so they're prioritizing the health of others over themselves. And so maybe they need a care coordinator, maybe they need someone to provide additional support. And also, when families are in crisis, I think that there is a thing that we need to normalize, that in communities that we are often serving, there are high incidences of drug use, or opioid use disorders, trauma, and also chronic health conditions that, if aren't being addressed, a lot of individuals are trying to survive or are in crisis mode, and it's hard to make decisions. It's hard to seek care or help or support. And so trying to get providers to understand the underlying and the root causes of some of these issues, that they can then begin to have compassion. And also, how they are addressing or trying to show support. And so by being able to pull back those layers and help providers to see beyond, the data, so that they can connect with their patients. And I do think that there is better outcomes when individuals understand that, like, there's more to the story. And sometimes you just have to ask, but providers often don't have time to ask because they're limited.
Yeah, thank you. Thanks, Melissa. I didn't realize how fast this hour went, actually, so I wanted to make sure I turn it over and see if anybody in the audience has questions that they'd like to ask our panelists. If so, the microphones are here at the front. And while you're thinking about that, I'll offer our panelists an opportunity. We teed this up as preconception care. So if there is something, if you could speak to somebody in that space, pay attention to, finish the sentence, what would you say? Start with Megan.
So I think I would say pay attention to knowing your resources, knowing your numbers, knowing the people around you that can advocate for you, and really connecting with them. Talk with your providers, and again, I'll say it again, don't stop asking for help. That is how we are going to move the needle, is to ensure our patients, our families have a voice, that we empower them. I love that we've used that word so many times today, that we empower our patients, that we empower the people around them, the doulas, the community health workers, the home visitors, the midwives, the providers, to work together and empower them to make this change. We can do it.
Dr. Price.
Well, I'm going to start with what you should not pay attention to, and that is social media. It has been so incredibly difficult. There's a lot of fear-mongering, a lot of false information on social media. I feel really bad for young mothers today who are trying to navigate what are really just bullets that come at you every single day, and you don't even know what to make of it anymore. So I encourage people to find really great childbirth education and support classes. So share that with people, direct them to the right information. One of the things that you should pay attention to is your own trauma. And so everyone has had some trauma, right, in their background, but particularly for certain populations, every encounter they've had with the healthcare system has been very traumatic. So some of the work that we're currently doing is making people aware that everyone has had trauma, to assume that, not to necessarily ask about it, and to come, at every patient from a place of understanding that they may have had negative experiences. If you have the opportunity to address some of your own traumas prior to having, prior to getting pregnant, great, but definitely prior to your birth experience and postpartum, so that you work through some of those things before you get to a situation where you're being asked to make decisions or be in an empowered space, and everything may come flooding back to you. So if you have that opportunity, there are organizations that will work with you and really get you in just, the best possible space for you to be able to do that.
And Galissa, finish this sentence for us. If you could say to one person in the preconception space, pay attention to...
Which question?
Oh, sorry, just asking if you to finish the sentence. If you were to speak to somebody who is considering becoming pregnant, what would you say to them from a preconception standpoint? Pay attention to, what's the most important way to finish that sentence?
So when talking about preconception, I think it's really important. A lot of folks don't really know what that means. And so I actually did like a whole wellness series where it was kind of talking about the life course perspective and trying to break it down, like, your health before you even think of being a parent impacts when you become pregnant and the outcome of that, as well as like the generational factors, such as like what things you may have that come from the state of your parents when you were conceived. And so you have an opportunity to let folks know what preconception means, and letting them know that, like, you don't have to just start thinking about your nutrition, or, if you're taking vitamins, or if you're drinking enough water, or do you have health issues that are chronic or being unaddressed. Oftentimes, individuals may not have ever had a primary care provider, because after they were a youth and their parents may have stopped taking them to the doctors, maybe they didn't have health insurance, or maybe, they didn't have time or think that it was important because they didn't seem to have issues, and then they conceive, and all of these things that are existing that haven't been addressed come, to the front. And so I think just starting them at, you don't have to be planning for pregnancy to be thinking about being healthy. And I think that just also letting them know what resources are available. I think that's the biggest thing. Like, a lot of folks feel like if you're not a parent or you're not pregnant, there are no resources. And, in Philadelphia, I think there's a big initiative to at least get individuals into having like a primary care home, making sure they have access to nutrition, physical activity, mental health and behavioral health. So connecting them to like health centers or low cost or free services is really important. But also just letting them know that it's important that you think about your health every day. And, we have youth care services that also try to educate the youth and to kind of tap in, because there's often a shame or kind of like we don't talk about certain topics. But I think that there is age appropriate information that individuals need to know, that are about their health, about their development, about their hormones, and things that they can expect. And if we can kind of do things preventatively or preconceptionally, I think that will at one point have better outcomes, because folks know what to expect, but also how to get connected. They know where to go. Instead of feeling like you're just out here by yourself, I think that creating a sense of community and support, that everyone can get care, is really important. So preconception is really anyone before they're pregnant. Anyone, at a point. It can be children, it can be youth services, it can be, adolescent or young adult. But I think that just tapping in and making sure that individuals feel supported, not just when they check off that box for your program. So making sure you have resources across the life course, perspective.
Yeah, and resources being the common theme, regardless. Yep. And we have a couple of questions in the room over here.
This question is more so geared towards Dr. Price. You mentioned the excellent work that Sentara is doing with navigators to improve outcomes. I was curious if they are currently or in the future planning work to increase use of doulas in order to support the uptake of the Medicaid benefit, and also community health workers, which was also their work was touched on a bit today, and many of us hope will be a future Medicaid benefit in the state.
Well, I can't speak on behalf of the health plan. I'm just the hospital CEO. So I know that this is on our discussion table, right? There's a wraparound thought process on how do we best serve our Medicaid patients with our Medicaid plan. I'll keep it specific to that. So I think you will see more and more wraparound services being supported by the Medicaid plan. not just doulas, but everything else that we haven't talked about. How do you reimburse for mental health? How do you reimburse, for the things that, people that tended not to have access to after 6 to 12 weeks postpartum? So I think you will see that. What we can currently do for the health system, for all of us combined, is open the pathway for doulas to come into our systems and facilitate that. So what does that mean? Well, if you show up in one of our hospitals, and somebody there says, oh, it's a doula and we don't want them here, what actually happens? So we need some standardized response to the acceptance of doulas and the inclusion of doulas into our birth space. One of the things that we're going to be doing in Williamsburg, and I don't think that we've announced this anywhere, so this is just as good a platform of any, is that we are actually going to be inviting doulas in the community to come and attend a session with us, that then once you've kind of sat with us and understand how it works in our hospital, you are going to be able to come in and attend any birth in an OR, be present for that mom, regardless of what happens, because we've all had a conversation together and sat at the table and said, hey, you understand sterile technique, you understand what all these things are and these reasons. We're removing the barriers for you to have access to women, even when high-risk things happen, which in my opinion is where a doula brings the most support, is when you don't have the perfect birth. It's when things are stressful and things are scary. That's when we start to see health systems actually excluding doulas from supporting moms. So we are breaking down that barrier, creating this pathway. They'll get a little badge that shows, hey, we're part of the team here, and you'll be able to come in and have access to that woman that you're supporting across the board. And, we're talking about volunteer programs, which sometimes are a little bit easier to implement than structured programs. So all of these things are happening and on the table across our system. But yeah, Williamsburg is starting to pilot this actual very intentional relationship that denotes you as, I am a part of the birth team. And that also helps bridge the barriers between providers and doulas, because it normalizes the fact that doulas are part of the team. And that's where we're headed.
We have one last question over here.
Yes, again, my name is Monique LaCroix from Renew Life, supportive and home agency from Newport News. I think this is directed maybe to all three of you guys, but how is it that we, as a normal, like a regular female, going into talking to our insurance companies, we may have insurance companies that we pay personally, or we have Medicaid, to make them understand that, because you said the barriers, or one of the criteria, the high-risk criteria was being on Medicaid, and I'm sure one of them is just being young and not knowing. So how is it that you guys, between Sentara, maybe Riverside, any of these systems, can talk to our insurance companies and kind of get them to inform us on a level, even the people that are paying out of their pocket, and knowledgeable of doulas? Because if the private companies are already doing it, we know it's going to be coming for Medicaid as well, and then that disparity, that won't be, I feel like that won't be one of those criteria. I'm on Medicaid, I'm looked down at, or I'm young, I'm looked down at. So if you guys can answer that. I'm sorry, I probably answered some and then ask questions on some, but anyway.
So I can speak to that briefly. So I know that we have people in the room. We have people here from Anthem. We have people here from United Healthcare. We have, of course, Sentara Health Plans. And so I think and we have DMAS here. So I think the big piece of this is to start that conversation by having the right people in the room. The people that are working on these policies and making these changes are part of the conversation, that we don't exclude them from the conversation, and that we tell them, this is what we need for our population, this is what we need for our communities, and how do we help you get that for our clients. So I think that you brought up a good piece, that it's not just the private payers, it's not just Medicaid, it's all of us, right? It's all of us having this conversation and having the right people at the table, which I think we have. I'm really happy that we have a good representation here today of some different payers.
And I'll very briefly follow up on that. This goes back to the navigation, right? The navigators that we're talking about span both our acute care side or hospital side and the health plan side. And so if you're in touch with that person from very early on in your pregnancy, those are the folks who are going to say, hey, have you thought about a doula? Here's how you connect to that. Here are your resources. Hey, here's your free childbirth class. hey, here's a baby shower, right? We're going to take care of you. Here's how you get access to food. Here's how you get access to mental health support. What can we do for you? How do you get food at home? Who takes care of your pets when you're in the hospital? All of these things that work together. So I totally agree with you that a lot of this is knowledge, and it's not just, how do you get it covered if you didn't even know that you could get it covered, is what you're essentially saying. So we are working on that by creating that awareness early on in pregnancy when we really don't know that patient yet. That patient could be with a private provider somewhere. Again, from the hospital side, we don't know you till you walk in that hospital in labor. We don't have that past relationship. So getting external navigators in as a system, that will help bridge that and make sure that when you come in to have your baby, we know that you are prepared and have the tools you need. It brings me to one other quick thing that I want to talk about on your earlier question about implicit bias. I think implicit bias training is great. But one of the things that we just did is a labor culture survey. How many of you are familiar with a labor culture survey? Yeah. What we did is we interviewed all of our providers and our nurses and our nurse midwives, and we asked them a series of questions through a formal survey, a standardized national survey. And we asked difficult questions, right? We asked questions about the autonomy of the woman to make her own decisions. We asked our physicians and our nurse midwives and our nurses the same questions. Things like, do you think our patients are coming in very well prepared to have a baby? Do you think that they have the support they need? And then we were able to compare the answers. And in the facilities where those questions were aligned, where the nurses had very similar answers to the physicians, to the nurse midwives, that's where we saw optimal outcomes. In the facilities where people were really far apart, right? One of the questions we asked was, are you personally afraid of vaginal birth? Right? That's an important question when you have high cesarean rates somewhere. We could see that huge disparity between physicians and nurses. And nurse midwives are really out there. None of them are afraid of vaginal birth, let me tell you. But that question on, do you think our patients are coming in well prepared? We know that a lot of our providers believe women are well prepared, but the nurses were saying absolutely not. And so this data is helping us to focus on where that discrepancy is in our culture. Everything starts with culture, and we're tackling it from that direction as well.
All right, thank you. And I want to thank our panelists for an exciting, engaging, and really thought-provoking panel. So to Megan Buchholz, Dr. Amber Price, and online we have Galissa Jones. Thank you to all of our panelists today. Appreciate your time. And I do believe lunch is next, but we'll let Melissa guide us in how this will happen.
Okay. Thank you so much to our panel. We really appreciate everything that you had to say. And Jaleesa, thank you so much for joining us from Philadelphia. It is time for lunch. So in the same room that you received breakfast this morning, please look to the left and the door is open. You can go ahead, get your lunch. We encourage you to please bring it back here so that we can hear from our keynote speaker, Senator Mamie Locke. Thank you again. And I have one other announcement, and that is we hope you will join us this evening for a networking reception. It's going to be held at Satay. If anybody's ever been there, I was here in January. I was there. Wonderful food. It's from 5:30 to 7:30 this afternoon. Please RSVP. I have a flyer that I can send to you, but definitely feel free to join us at 5:30 today for a networking reception at Satay. If anybody needs the address, I have it as well. Thank you so much.
voice. All right. Good afternoon. Is everyone enjoying themselves? Great. Good information. All right. So I have the honor to introduce our luncheon speaker. She said don't make her, she doesn't want her introduction to be that long, but I'll give you some highlights. So Senator Mamie Locke is a native of Jackson, Mississippi. She currently resides in Hampton. She earned her PhD in political science from Atlantic University, later Clark University. She's a professor of political science and history at Hampton University. She also serves as assistant dean and dean of School of Liberal Arts, and she has published extensively on issues of race, gender, and public policy. As elected official, she was the first African American woman to be mayor of the city of Hampton, and after 8 years of service, she became the third African American woman to win a seat in the Senate of Virginia, representing the 23rd District. She serves on the following committees: Education and Health, General Laws and Technology, Rehabilitation and Social Services, Finance and Rules, and she is the chair of the Senate Democratic Caucus and Rules Committee. And she also has served as chair of the Virginia Legislative Black Caucus. And if you know of anyone who's very passionate about our people and the underserved, she's the one. You can go on to the website, the Virginia General Assembly website, or Google her and see her on the floor. And her speeches are absolutely phenomenal. And how do I know? Because I was her first political science student when she came to Hampton many moons ago. But she is definitely passionate about everything she does. We couldn't get a better legislator than what we have representing the 23rd, but representing just people across Virginia and raising the issues that need to be heard. Please welcome Senator Mamie Locke.
Good afternoon. I guess Gayleen didn't realize by telling you all that she was one of my former students that she aged herself too. Okay. Thank you all so very much for being here for this very important conversation. And I would ask that they bring up my slide. And while they're doing that, I would like to acknowledge Senator Ghazala Hashmi, who serves with me in the Senate of Virginia. If you could go back one, please. Go back from the very beginning. Okay, this isn't working for me. Okay. And I also would like to acknowledge Delegate Alex Askew, who is in the House of Delegates as well. And I want to thank Gethsemane Baptist Church for hosting us here today, as well as thank Sentara and Celebrate Healthcare for pulling us all together here today. And I want to talk about Black maternal health care and why it matters, but I also want to talk to you all about the fact that okay, this is going beyond where I'm supposed to be. This is not advancing the slides the way they're supposed to. I'll get this right in a minute. Okay. Okay, I've not just started my interest in Black maternal health care. I doubt very seriously if very many of you will remember this particular issue. But these were billboards in many third world countries across the world back in the early 1970s. And I was actually in graduate school at the time, dealing with the promotion and sale of infant formula in the third world. And they talked about genocide for profit. Then when I started working at Hampton University, there was this whole issue about this sale of this infant formula. And the formula was being sold by Nestle's and the Nestle's Corporation. And it had to do with the fact that Nestle's was promoting the sale of their infant formula at the expense of these mothers who were actually feeding their babies. And in 1974, a report entitled "The Baby Killer" came out. And the report actually accused Nestle's of causing illness and infant deaths in poor communities across the world, particularly on the African continent and in South America. And they were promoting their infant formula products at the expense of breastfeeding. And actually saying to these mothers, it is better for you to bottle feed your babies using our wonderful infant formula rather than breastfeed your baby. And this report that came out that was called "The Baby Killer" essentially went through a whole litany of what Nestle's was doing in promoting this infant formula. They were saying to these mothers, we'll give you free baby bottles, we'll give you all of this information, we'll give you free formula to start with, without giving them any real instructions on how to use the formula, not understanding the literacy rates in a number of these countries that mothers couldn't really read and understand, how to prepare the formula. Remember that in a lot of these countries, there wasn't a lot of potable water. So they were mixing this formula with water that would end up actually killing their children. And so they were encouraging the mothers to use this water and mix it with this formula that ended up killing their children and making the children also very malnourished. And they would also say, this is much, much better for you and for your babies than breastfeeding. So they were discouraging breastfeeding over using this infant formula. So at the time, by the time I got to Hampton University, this had become a worldwide thing to boycott Nestle's. Now, this was hard for me because when you got the list of products for Nestle's, it was a whole lot of products. And I loved me some Stouffer's because Stouffer's was on the list of Nestle's products. But I'm also one person who believes in, if you're going to commit to an issue, you have to commit all the way. I gave up Stouffer's. I gave up L'Oreal. That's on the list. And that boycott extends to this day because Nestle's never, ever said that they did anything wrong. To these mothers, to these families in any of these countries, they still continue to market these products in the exact same way that they were marketing them in the 1970s, well into the 1980s. And I remember viewing a hearing that Senator Ted Kennedy was asking questions of some of the heads of the corporation, about what they were doing. They never owned up to anything that they were doing wrong. And so when the boycott happened, I went all in. Okay, sorry, Stofers. Got to give it up. Got to give up L'Oreal. And I know some of y'all out there like Kit Kats. That's one of the products. So I've been a part of this whole process of making sure that we're doing right by women when it comes to maternal health care for a long time. And we've heard some of the statistics already, but I want you to know that every 7 seconds, a woman or newborn dies or a baby is lost to stillbirth. Most of these deaths are preventable with quality health care before, during, and after childbirth. I have many friends who've suffered multiple stillbirths, family members who have dealt with children born prematurely and having their babies in the NICU for months. Just last week, a friend told me that she was pregnant, and in congratulating her, about, learning about her pregnancy, I said, well, what do you want to do? What are some of the first things you want to do? And she said, I tell you what I'm not going to do. She said, I'm not going to have a certain type of physician. She said, the physician that I want is an African-American female doctor. She said, because I've heard the statistics. I know the information. I've heard the stories. I want to make sure that I go through this pregnancy in a way that's going to lead to a positive outcome for both me and this baby. And I know about cultural bias, and I don't want to have to deal with that. I want somebody who's going to hear me when I talk about what I'm going through. And I know that if I choose the right physician, that I will be heard. I promise y'all it ain't me. Okay. So do you know who these two women are? One of them died at the age of 36. The other died at the age of 40. On my left is Jessica Pettaway, who was a beauty influencer who died from cervical cancer after she had been misdiagnosed for months. And as I said, she died at the age of 36. She had started complaining about intense vaginal bleeding. She went to the hospital after her husband found her. She'd passed out, so her husband found her. And he took her to the hospital where doctors told her, oh, it's just a case of fibroids, and sent her home. She still was having the exact same problems of the intense bleeding, and despite another hospitalization, she was still treated for fibroids, and was told, it's nothing serious, the bleeding is going to stop after a period of time, and the bleeding did stop after a period of time. But what it was replaced with was what she called labor-like pains. And the bleeding did return and wouldn't stop. So she was hospitalized again, and after 10 blood transfusions, this doctor finally said, oh, I guess we need to send you to an oncologist. So she goes to an oncologist, has a biopsy, and after she wakes from anesthesia, this doctor that she had been seeing says to her, "Oh, I guess it wasn't fibroids. You have stage 3 cervical cancer." And in her reporting all of this that had been happening to her, she said he very casually says this to her, that no, stage 3 cervical cancer. Yeah. And she dies 10 months later. Yeah. So this is one situation where she was not heard by this physician, even after telling them, something is wrong here. Crystal Anderson, she and her husband were trying to get pregnant. She got pregnant and lost her son to a stillbirth. She got pregnant again with her daughter, and her daughter was born in the 21st week of pregnancy. She lost this daughter into a stillbirth. And while she was in the hospital, she contracted sepsis. And she died shortly after her daughter was born. Crystal was a cheerleader for the Kansas City Chiefs, a yoga instructor. And so, in good health, died at 40 years of age. So Crystal Anderson and Jessica Pettaway deserved better than what they received from the healthcare industry. And so certainly, African American women, these are just two stories of what has happened to African American women in the healthcare industry of not being heard. I can tell you my own, but I'm not going to even go there. Of a doctor asking me as I'm sitting in an emergency room, "Why are you shaking?" Well, hell, if I could tell you that. I wouldn't be here and I wouldn't need you. Suffice it to say that I ended up in the ICU for 4 days with sepsis because I was misdiagnosed in the emergency room. So we all understand the Black maternal health crisis in this country. And we understand that there's a lot more that needs to be done. You've heard it this morning on this stage about what needs to be done. So I'm going to talk specifically about legislation that was passed in the Virginia General Assembly this session. Let me start by saying I am a politician. So I'm going to talk a little bit about the legislation, and there's one bill in particular, some of you've heard on this stage about bias, and we're going to talk about that bill because one of my people is here who helped me with that legislation. It's still in limbo land, but we'll talk about that one. But we're going to talk first about House Bill 831. House Bill 831 expands the composition of and scope of work at the Maternal Mortality Review Team. This team was actually put together previously, so it already exists. But what this legislation does is to expand the composition and scope of work of this team. The legislation was introduced by Delegate Ray Cousins and Senator LaSharice Aird. And Senator Aird struck her bill because she thought it was going to cost too much money But we worked with Delegate Cousins to figure out a way where it wouldn't be such an expense, so that we could move the legislation forward, and essentially directed the Office of the Medical Examiner and the Maternal Mortality Review Team to convene a work group to expand the work of the team. And the only thing that we want them to do is just do a little bit more work than you're already doing, develop some criteria and procedures regarding the collection of maternal morbidity data, and expand your plan to include some data collection, some data review, and development and implementation of policies and recommendations. Just tell us who's dying and where. And, just put that as a part of your collection data so that we will know what's going on across the Commonwealth. That's all we're asking. It's not going to take out that much more of your time to do this. So the governor did sign it. This one is a little bit different. Remember, the question was raised about bias and cultural competency? Senate Bill 35, I have been working on for the past 3 or 4 years. I introduced it again this year after having extensive conversations with the Medical Society of Virginia, because they had been my main opposition to the legislation. And so, in having a conversation with them about the bill, we finally were able to get them on board. Catherine Haynes is here. She works with the Public Policy Center, Virginia Interfaith Center. And so we began working together with the Medical Society. Okay, what will it take to get you to support this legislation? One of the first things was we changed it to unconscious bias. Okay, that makes you happy. And cultural competency training as part of the continuing education requirements for licensure for physicians and nurses. And it requires the board of, then we had an issue. If folks don't like your legislation, one of the first things they will do is to slap on what's known as a FIS, a fiscal impact statement, to make it so uncostly that they say, oh, well, this is going to cost too much money. We can't do it. So that is one of the first things that happened to this bill. And it was like somewhere in the vicinity of $600,000, I believe, that was slapped on the bill. So it was like, okay, all of a sudden it has a FIS. Okay. So how do we get rid of it? We took out, I believe it was the Board of Health or somebody we took out. Said, okay, we took out somebody and said, okay, we don't need them. And we put in the neonatal perinatal collaborative as the agency. And so we required the Board of Medicine to report on the training to the Department of Health and the Virginia Office of the Neonatal Perinatal Collaborative to be our agency to work with on the training. So this bill got out of the Senate on a vote of 36-4, which very clearly says that this is bipartisan. My co-patron was a Republican senator from out west. So this is a collaboration on the fact that this is serious. You know, we want to do work in this area to make sure that we're getting people trained about unconscious bias and cultural competency. And it wasn't just about the training. The Neonatal Perinatal Collaborative was also going to collect data to determine how this was working, and is there something that we can do better in the future to make sure that folks were going to actually be doing what they're supposed to do. So this was what we would call a 7-day bill. So it went to the governor's desk before we adjourned, which meant that he had to act on this bill before we left Richmond. And he did so. And this is what he did. He completely changed the language of the bill and said that the Board of Medicine shall require that persons licensed by the board who work with maternal populations, including persons who work in fertility care, prenatal care, birth care, and postpartum care, complete 2 hours of continuing learning activities that address maternal health care for populations of women that data indicate experience significantly greater than average maternal mortality, including African American, Indigenous, and Hispanic women and women in underserved rural communities. Licensees subject to this requirement shall take such training no later than July 1st, 2026, and shall attest to obtaining such training using a form provided by the board. Can somebody raise their hand and tell me what this means? And is this what Senate Bill 35 was requesting? Does this bill say anything about unconscious bias and cultural competency as he amended it? No, it does not. So before we adjourned, we simply said, we'll let this bill go by for the day. When we go back next week, I will reject the governor's amendment and ask that the bill be accepted in its enrolled form. For those of you who don't understand that process, that means I will be rejecting this amendment and ask that the bill be accepted as it left the Senate floor when we passed it 36-4. Then it will go back to his desk. He can either sign it or he can veto it. That will be his decision. You either want unconscious bias and cultural competency training in the Commonwealth of Virginia or you don't. Make a decision. Don't wuss out with this kind of language. So it will be his decision. I think that's why they picked me to carry this bill. So. Okay, we also had doulas were here today. They're still here. And we had a piece of legislation, Senate Bill 118, which I also carried, coverage for doula services. The bill requires health insurers, corporations providing health care subscription contracts, and health maintenance organizations to provide coverage for doula care services provided by a state-certified doula. What this bill means is that coverage will cover a doula who provides 8 visits during the antepartum or postpartum period and support during labor and delivery. So this will go beyond just Medicaid coverage. However, to get the bill passed, we had to agree to the bill being, having a reenactment clause put on it. That is, it has to pass again next year. And it also required that the Health Insurance Reform Commission look at this legislation, take a look at the language that we put in the legislation, and determine whether or not doula care services are an essential health benefit. And if they agree that it is indeed an essential health benefit, they can say, okay, fine, we like this, we like the language, bring it back, and as we bring the bill back next year, it can be approved as we presented it this year. We will be going before the Health Insurance Reform Commission to make that argument, that this is indeed an essential health benefit benchmark, and it needs to be approved as we presented it. And if we get their approval, we can bring it back next year, and doula services will be insured as we requested. You see, one of the other things that has happened during this session is that there was a resolution that was adopted establishing Black Maternal Health Week, the week that we are now in. House Joint Resolution 44 was patroned by Delegate Destiny LaVere Bolin, which designates April 11 through April 17 in 2024 and in each succeeding year as Black Maternal Health Week in Virginia. So henceforth and forevermore, this week will be Black Maternal Health Week in Virginia. We also, for the first time, established a Virginia Black Maternal Health Caucus, and it is open to everybody, but of course it was primarily African American legislators who established this caucus and joined this caucus. And this caucus met for the first time during this 2024 session. And our caucus is committed to improving Black maternal health outcomes in Virginia. We will work with any and all leaders in our regions throughout the country to identify maternal health challenges and opportunities across the health spectrum. Our objective is to move Virginia from the bottom of the ranking for maternal health, and we specifically want to join the national conversation on Black maternal health. Our focus is improving medical education, mapping the Black maternal health landscape in Virginia, addressing disparities, tackle systemic issues contributing to Black maternal health disparities, advocate for legislation by championing bills that mirror federal initiatives for equitable outcomes like the Omnibus Bill, community engagement, foster dialogue through town halls, stakeholder meetings, and legislative briefings, create public awareness, organize events to raise awareness about the urgent need for change. This initiative represents more than just legislative action. That's not simply what the Black Maternal Health Caucus is about. It is a moral imperative that calls for our unwavering commitment and collective action. We want to work with any and everybody who cares about this issue. The disparities in maternal health are a stark reminder of the inequalities that persist in our society. As legislators, we see what the problems are, and it is our duty to ensure that all Virginians, regardless of race or background, have equal access to the care and support they need during one of the most critical times of their lives. And that is our responsibilities as legislators, and it's our responsibilities to ensure that there are positive outcomes in maternal health care throughout this Commonwealth. And I thank you for the opportunity to speak to you today. not supposed to take questions. Better get me before I run.
Let's give her another hand. Thank you so much. Okay, I hope you enjoyed the senator and give her another round of applause. She certainly outlined what is happening in Virginia and how she is actively, and as Dean said, she's passionate about making sure that we are moving forward with things that we want to do in terms of just having better health outcomes, maternal health outcomes. I read about Ms. Pettaway, and I was really surprised to see and hear about how she was just having vaginal bleeding for months and went to one doctor, misdiagnosed, went to another doctor after her husband found her, nearly passed out, misdiagnosed. And in one of the accounts, it said that she actually had produced a clot that was so huge that she wasn't sure what it was, and yet still misdiagnosed. And then she goes to another physician who takes her seriously and finds out that she has cancer. Cancer. In this country, we should be able to go to our physician, be heard, listened to, explain what's going on with our bodies, and not have to wait months and months to be told that, oh, now you have a terminal condition. It's actually quite maddening. And I know that Senator Locke was up here, and she has certain privileges that I do not. So, and as my friends who know me well, I'd like to remain Melissa and not Missy. So with that being the case, let's keep moving on. But again, highlighting the fact that this is very real. And it should not be happening when we have tests. And let me just put it this way. If a virus, an unknown virus, could move across this planet, come to this country, and within 3 years, we have testing, we now have a vaccine, we did what we needed to do, surely we can put resources into things that are that can be prevented from Black and brown women dying. We can do this. I'm passionate about it. We can do this. And that's as far as Missy will go today. That being stated, let's move forward with our other maternal health resources. So many of you may be from community-based organizations. We're in the house of a faith-based organization, and sometimes you want and are doing the great work, but you just need more resources on how to do it. So we wanted to make sure that we are bringing up our partners in this work. As I mentioned earlier, HRSA, the Health Resources Services Administration, has put forth over $90 million into maternal health outcomes and increasing maternal health outcomes from Black and brown women. So we want that work to continue. So with that, I'd like to bring up my HRSA colleague, our regional office, all the way here from Philadelphia, Rhonda Jackson and Christine Woolslayer. Please give them a welcome as they come.
Okay, I think I have some slides, if you can pull them up. In the meantime, I just want to say, I have this screen in front of me because my notes are on it. I'm Christine Woolslayer. I'm a public health analyst with the Health Resources and Services Administration, as is my colleague Rhonda Jackson, who you'll meet in just a moment. I've worked for the government, the federal government, for about 8 years now. I've only been with HRSA for a little less than a year, but I was really excited to come over to this department. Because prior to coming and working for the federal government, I was a Title X grantee in southeastern Pennsylvania, part of the Family Planning Council. So I was on that grantee side of it. I knew what it was like to write those applications. I knew what it was like to have to report, all the data. I knew what it was like to have to balance, funding and workforce and supplies. So I knew that side of it. So coming over to this side and finally getting to working with HRSA is really great and exciting for me, because HRSA is, I believe, the second biggest funder in the HHS, the U.S. Department of Health and Human Services. And still no, oh, okay, I see your slides, great. So this session is going to be on Grants 101, which Rhonda will do in just a few slides. But first I want to start out, give you a little more data about HRSA. Okay, so this is who we serve. I'm not going to read everything, but last year we served 30.5 million patients, more than 58 million pregnant people and children. We helped a lot of over 500,000 people with living with HIV. We also work a lot in rural communities, and we also supported 3.7 million infants with different testings and that sort of thing. Sorry, this is hard to do two things at once. I keep doing this. Okay, so this is real quickly. This is HRSA's organizational chart. There's a lot of different pieces to it, and I'm going to go over a few of them. But just so you can see where we are, we're in the Office of Intergovernmental and External Affairs. So we're kind of like the public relations part of HRSA. We sit in Philadelphia. We're part of a regional office. There's 10 regions. And our job is to kind of go out there, share about the resources we have, talk about the grants that we offer, and be that connector between you and the headquarters of HRSA. So I'm here, Rhonda's here. If you want our cards, we have them. We're happy to connect with anyone, answer your questions. So just keep that in mind. This is going to be one of those days. Okay, so this is our priorities this year. It's Carolyn Johnson is our administrator, and then our three focus areas currently is substance use and mental health, health workforce, and then also maternal health. So you can see that maternal health is really a big piece of it, and I can tell you that Carolyn is very focused on maternal health. She's always out there doing more and more and trying to get more funding. If you're looking right now at the funding that Virginia currently receives from HRSA, again, we do send out a lot of funds. There's a lot of grants out there, so that's why I'm excited about this presentation. And you can see that maternal health in Virginia gets over $31 million. That includes like the Title V program, maternal health program. It's also the home visiting program, as well as a bunch of different other programs that we offer. So real quickly, so I mentioned the maternal health programming, and again, this is kind of a lot of what we work on, is the Title V Maternal Health Child Block Grant, the MICV Home Visiting Program, and also Healthy Start is another big piece of what we do. And we do serve so many different patients through that funding, so it's really exciting for me to kind of be here, and I'm meeting people who work in this space, so that's always great for us. work of MCHB, it's to make sure that all moms, pregnant people, babies, children, and youth are physically and mentally healthy. There's a lot of guidelines that kind of come out of the work and the evaluation work that we do around children's checkups and newborn health. And we also do a lot around workforce development and workforce training and workforce funding. So I'll talk about that in just a second, but keep that in mind. Now, the thing that we're most known for is the health center program, and that's the federally qualified health centers. I know a lot of you probably might be familiar with that. So we have a big part of our funding goes to this space. Last year, again, they served 30.5 million patients. They're doing a lot to kind of make these healthcare centers. I can tell you, if you work for one, you do a lot. You don't, I don't want to say a little, but you know, you're stretched a lot, and we ask a lot of you. We really are grateful and appreciative of all that you do, and we're always trying to get you more funding, just to let you know. But, you know, they do so much. Some provide dental services, some provide mental health services. You know, they just do so many amazing things. They are such a great connector. They do outreach. They do case management. So we just are so appreciative of all that you do. So this is just how to find a health center. You probably are very familiar with this, but there's a very easy map on the HRSA website where you can just enter in your zip code and you can locate different health centers and also find out what kind of services they offer. Another program we support is the Ryan White HIV/AIDS program. A lot of money goes out to this every year, and there's been a lot of successes. I know that the viral suppression rate is a real big win for us, and for all of those who work in this in the states who are funded, it's almost 90%. So this funding goes out to all the states and supports not only their care, their treatment, and other services as well. This is really hard to do two at once. So health workforce, this is one that I really want you all to like kind of listen and hear about this, because there's a lot of health workforce programs that are coming out through HRSA. They do like education through different training centers. That's for maybe continuing education services. There's also loan and scholarship repayment offerings. So that's another one. There's the Nurse Health Service, National Health Service Corps. But if you go on HRSA and go into the office of, I just do HRSA Workforce Scholarship, HRSA Workforce Loan Repayment, there's so many things out there that are available. If you, and this is especially interesting for people who are kind of maybe starting college or even in high school thinking about how am I going to pay for college. If they're interested in going and becoming a nurse or a social worker or a dentist or a counselor or a doctor, and they're willing to serve in a high priority needs area for 2 years, they get a lot of repayment. If you're a physician, you can get, I think, like $200,000 a year repayment for loans, and then it goes lower for that. But it's significant, so that's something to really pay attention to. But you do have to commit to work in an area for 2 years, and they actually might live in one of those areas, so it might not be that big of a challenge. And then also for those of you who have already gotten out of school and didn't know about that program, there's also loan repayment programs. But again, it does require you to serve in an area that has a high priority need, or a HPSA. So make sure you pay attention to that, and just go on that site. And then if you have any more questions about it, again, I'll have my cards over here, and feel free to give us a call or give us an email, and we'll get you connected to whoever has those correct answers, because we're the connectors again. Okay, rural health is another big focus area. This is something that Rhonda does a lot of work around in this space, because we know that in our region, which is Pennsylvania, Virginia, West Virginia, Delaware, DC, and Maryland, there's a lot of rural areas, Region 3 is really interesting. They mentioned earlier that, Virginia has the coast, it has the urban areas, it has, the rural areas. So it's really a balancing act to try and figure out, what the needs are and how to kind of meet all of those needs. So that's one thing that rural health does a lot in that space. And they also have a lot of funding coming out. One of the bigger programs right now is around substance use disorder. So there's a lot of funding coming out in that space as well. And I keep talking about funding, but I'm going to talk about that more toward the end of the presentation. But I just want to quickly say that So this is our department, and there's Alexia. I don't know if she's still here. She was the moderator for one of the first sessions. But this is kind of the people that I work with. Again, this is our office. Our core functions are around engaging, serving, engaging with stakeholders, figuring out different collaborations. I'll talk about that in a minute. Providing outreach and education, what I'm doing now, and responding to health issues. So we're actually the boots on the ground, the ears at the table, boots on the ground. I forget what the saying is, but you talk to us. When we hear something, when we go to these kind of meetings, we report it back. And then it kind of trickles its way up, or down or across the ladder to the people that, can make the bigger decisions. So, talk to us about the challenges you're having. If you have a program that's innovative that you want to share out, that's another way that we could be helpful. So just, know that we're here and we're a friendly group, especially Rhonda. She's sweet. Okay, Rhonda, now it's your turn to do the two thing.
Good afternoon. I'm going to try my hand at this. Thank you for the opportunity to be here this afternoon. My name is Rhonda Jackson. I too have been with HRSA for a number of years, working in the regional office. Christine did a great job of setting a landscape of HRSA, and so you've heard about just some of the many 90 programs that we have across a broad scope of areas. And so she mentioned the Maternal and Child Health Bureau, but even in the other programs that she mentioned, there are various programs that are embedded in those different areas, the Bureau of Primary Health Care, the Federal Office of Rural Health Policy, that are really maternal and child health populations. So I always say, make sure you look at all of those grants. Don't just think maternal and child health, because there really is opportunity across the board HRSA spectrum. So having said that, I'm sure many of you are looking at me and saying, okay, where are the grants? How do I get this grant? What's the magic secret? There's not a magic secret. However, there are various steps that you can take during the grants process. And so I just want to talk a little bit about that today, just some tips and tricks on really looking at those HRSA grants and how to apply. And much of what I also will share, you'll see applies really across many of the HHS programs, just some general, even external grants of how you want to think about if you're considering applying for a HRSA grant. And now I see what Chris meant when she said this is challenging. Okay. All right, so let's talk a little bit about the grants process. So you're thinking about doing a grant. You haven't applied for a federal grant before. Where do I get started? There are some things that you can do now before you even begin writing a grant, or are not under the timeline of having to do a grant that you can do to get started. And the first of which is registering for a few systems if you haven't already done so. Many of you may have done this already, but there's the SAM, the System for Award Management System, that you must register for. And this allows you to, enables you to be able to do business and get a number and an identifier number. And so along with that, you would then also identify the person at your agency, your AOR, Authorized Organizational Representative, that is allowed to represent you and do business on your behalf, and then register with grants.gov. So I made that sound really easy in 3 simple steps. I will say, if you haven't done this, start it now. These systems take time. There's emails that go back and forth. You've got to check that spam box. Certain people have to correspond and connect with one another. And so I would encourage you, if you've never done this before, these are free. You don't have to pay anyone to do these things for you. You can do these now and have these things set up so that when you're ready to certainly apply for a grant, it is available and you've set up all these things and are good to go. Once again, this is the contact number. You can register with them. It's free. It'll give you all the other additional information you need. The one thing I would highlight is that once you get registered with the SAM system, you do have to renew it annually. So the person that was registered last year that maybe left their position in November and now you're writing a grant in January, and you say, who's getting that email? You want to make sure you look at these systems on a regular basis to make sure you have your designees in place and updated in the system. A little bit more about SAMS.gov. It really gives you a point of contact and the designees that can do work on your behalf and applications on your behalf, and so that's why this is very important. In addition, grants.gov. All of our grants can be found in grants.gov. They're submitted electronically now, and so certainly if you do not have a profile in grants.gov, I would highly encourage you to do that. As you can see, that too must be updated annually, and then that password, I know I have 5 million that I forget every month, must be updated every 90 days. So also keeping that in mind for the systems as well. And they have 24-hour, 24/7 support available for this, as we know people are often working on grant submissions and things. So please do, if you have not already taken a look at grants.gov, take a look at that, and I'll talk a little bit more about that in a minute. Once again, another authorized organizational representative is included in this system, and so you'll want to take a look within your agency to who you're authorizing to do these functions. So now, where do I find the funding? I mentioned grants.gov, but that's not the only place. So where and how do I find these funding opportunities? So for HRSA, HRSA has a grants page. This is just one snapshot. If you go to HRSA.gov, right on our home page, the second tab you'll see is grants, find funding. So all of the grants that HRSA currently has open are listed under this header. Not only will you see the grants that are currently open, but you will see grant opportunities that have closed. And you may say, well, why is that important? Perhaps there's a grant that you were interested in applying for or didn't know about, just learned about. You'd be able to go on and see the past description of that program, what they asked for, the type of things that they're looking for in a grant application. And so that way you can start to begin now to think about the next application cycle and use that information and do some earlier planning, because we know those days count when it comes time to write for a grant. The funding opportunities will be listed. You'll see the date, when it closed. So these are just screenshots of what that page will look like. I encourage you to look often. It is updated very frequently. So what may not be there tomorrow could be there the day after next. So I always encourage people to look at that often. And then you can view the grant details. This may direct you to more specific details about that grant, a description of the grant itself, in terms of what's available, how many awards, and the focus of that grant. So you'll be able to get this off of that website. The next system we have is grants.gov. You heard me mention that. Although you may start out on the HRSA.gov page, it will often redirect you to the grants.gov page, or you could just start at grants.gov and you can search for grants. One thing I will share, there's multiple ways to search for grants on grants.gov, not just for HRSA, but many HHS agencies. So certainly, if you haven't taken a look at grants.gov before, I encourage you to take a look there. One thing I'll highlight is that they have not only posted grants that are open, but they also have forecasted grants. And the reason I want to highlight that is because that's a way to see the grants that are proposed for that fiscal year or that are going to be coming up. So if you have an idea, a grant may not be open now, but they're projecting that in winter 2024 or summer 2024 that grant will be available, consider this an extra heads up time to start to think about, oh, I have a program. Maybe we should start pulling some things together so that when that grant comes out, we're able to apply, because we know those days count. So I really always highlight, look at the forecast, particularly right now. I know that there's a number of grants on the HRSA forecast that have not come open for application yet, but are projected. So if you want to know what HRSA is planning to fund, that is a great way to see. Each grant has a set of instructions that goes along with it. And as you can see here, you can preview the application. You don't have to apply for it right away. You can have a time to really look at it and then look at the instructions and all the information for that particular grant. And as I mentioned before, grants.gov has a number of supports available so that you don't have to feel like you're going down a rabbit hole for that grants.gov is there to support you. I say get a subscription. As I mentioned, these things change often. You can get a subscription in grants.gov and register for that either as an individual or as an organization so that you will get notices when grants become available. That's very important because once again, this information changes very frequently. I have one myself and often use it to keep myself up to date in terms of grants that are coming available. So I would just highly encourage you, if you haven't considered that, to do that. So next I want to talk about the Notice of Funding Opportunity, and I just want to share, this is really the place where you will find out everything you need to know about applying for a particular grant. It is the document that tells you everything you need to include, what they're looking for, and other key tips. And so I'd highly encourage you, once you open up a Notice of Funding Opportunity, read it again, walk away from it, come back and read it again, share it with somebody else in the office, pass it around, but really read that document and it will give you all the information you need to know about the funding opportunity itself. Most funding opportunities include some basic information, the program funding opportunity description, contacts, eligibility information, what type of organization do I have to be to get these funds. All those things are filled out in a notice of funding opportunity. Many include an executive summary early on in the document, a snapshot of what the funding opportunity is for, its purpose, start date. So it's great to read that executive summary, but then you got to keep going into the other pages as well. Don't stop at the executive summary. But this will help you to understand if it's something that you'll be interested in. One other piece I wanted to highlight in a notice of funding opportunity is the application and submission information. This is where it will give you the guidelines and tell you the types of things that need to be included in the content, the format, the number of pages, the point breakdown, the different sections, and the criteria. People often want to know, how is my grant going to be evaluated? And this really tells you what is the criteria that's going to be used. What section do I want to spend more of my time or make sure I focus in on or hone on? So this really does highlight it in the application and submission information. So these are just clips from an actual notice of funding opportunity. And so the format may change, but the information is contained in it. Another question we often get, how's my application going to be reviewed? Applications at HRSA are reviewed by an objective review committee. They are not reviewed internally by staff like us. They are reviewed by experts such as yourselves that are reviewers of those applications. And so it shares the criteria for which those reviewers will be reviewing that application and scoring that application. So there's no secrets there. What you see on paper is what they're using as the criterion. So if you want to know what they're using as their rubric, that's it, and it's been laid out in the notice of funding opportunity. Another question is often about funding preferences. Do we get extra points for something? That will often also be included in the application review section of the document so that you'll be able to see that there as well. And then contact information. You may have a question. Is my program, will it be eligible? Will it fit? Is this something that we can do? You can use those agency contacts. Please don't hesitate to reach out to them if you have questions. We've gotten questions in our office, and we're happy to get the answers for those. So please do, if you have questions while you're thinking about a grant, to reach out to us. I just mentioned previously the HRSA review process, and once again, those ORC panels are pulled together with stakeholders that have expertise in those areas, and so it is an objective process. And I'd encourage you, I'm going to talk about this in a minute, but if you have interest in being a reviewer, we are always recruiting for reviewers, so that's also a great way to learn about HRSA. And then there are often companion guides, documents that give a little bit more information about technical aspects or detailed instructions about some of the forms and systems that we use to do applications. So I put in my plug, become a HRSA grant reviewer, become a HRSA grant reviewer. You want to know what goes into that process? If you've never reviewed an application, if you want to know what reviewers are seeing, if you want to see what's happening across the country, you can become a HRSA grant reviewer. The other thing is you do get a stipend for this. We're not asking you to do this for free. So if there was some more incentive that you needed there, hopefully that helps as well. But certainly we are always looking for expertise. And it's just a great way, I think, and a great opportunity to really share the information that you do have and be able to participate in that process. You register in a system, you list your expertise, your resume, the system takes you through all of that, and then you're put into a database that's called for these various panels, which are done virtually. So the other thing is you don't have to go traveling down into Rockville, Maryland to do that. So just want to go through a few tips. You'll see all this in the material, so I'm not going to go through everyone in great detail because I know we want to get to some resources, but just a few tips for submitting the application. And so one certainly is doing the research, making sure that you learn about the grant program. There's multiple ways to do that. You can look at the history of the program. Our office is able to connect you with grantees maybe that have had that program in the past, really looking and understanding your understanding the application requirements, so reading that NOFO early on to make sure before you invest 10 hours in writing a grant application, it's a grant you want. Recruit a team internally, of course, if you're able to. It always helps to have a team to draft the application. You're working with your consortiums or networks or community partners. Pull them into that process as early as possible so that you can also share with them the various steps you're taking. You'll probably need them for information. So really recruiting a team to do it. Certainly nothing wrong with having a grant writer if you have that, but even then having a team available to support that grant writer will be important. Respond to the guidance. This one I can't say it enough. It's really laid out what they're asking for. So really respond to that guidance. It makes it easier for the reviewer to review your grant and really award you the points and ensure that you're meeting the criterions as they've been described. Then review your application, read it, have someone that wasn't working on it read it, and give you an objective perspective from that grant as well. So in terms of the thinking about it, just making sure that you've read the funding announcement, making sure you're eligible to apply and reviewing the eligibility for that particular grant, and then being prepared to get that grant when you get it. So some common mistakes. Start preparing the application early. Generally, applications will come out 60 to 90 days before they are due. And if you use the forecast, you may have even more time to think about that. And that's just needed just to have time to pull together partners, to pull together the SAMs and the grants.gov pieces that we're talking about. Follow the NOFO instructions, attachments, MOUs, things that you may need to include, other information, include that. Keep your audience in mind of who will be reading it. The people that will be reading your application may not be from your area, and so you want to make sure that you're including information and writing it up in a way that anyone will be able to know and appreciate all the details of the program you may be proposing. Be brief, concise, and clear. Certainly, I know we could all write for days about our programs, but we just want to always make sure to be as concise as we can while conveying the important stories that we need to convey in the grants, and to organize your application well, and then also show fiscal stability. So you write a grant, you prepare a great program, and then you take it to a fiscal officer or a budget officer and say, hey, I need a budget for this grant. Include them early in the process. They are a part of telling that story as well of how you're going to use those funds. So really make sure that you're pulling in your budget people. It may be, or you may be the budget person. You may be the right grant writer, the budget person, all of the above, but make sure that you're including them in that. Attend to technical details at SAMS.gov, grants.gov, and different systems, and then the use of attachments, just making sure that you're even giving those in the formats that they've been asked for. And then lastly, just to review the information and to submit it. Most of the applications are submitted electronically at this time. So common mistakes, what usually do we see that happens is that it's 11 grants, so usually do it like 11:59 p.m. On a particular day, and so you're busy typing, it's 11:57, you're ready to hit the button, and then it says, oh, you're not the authorized representative. You're saying, what? I thought I was. So we don't want that to happen. So register with grants.gov, submit early, make sure that SAMS.gov registration is up to date. Make sure you're checking the spam, that you have the right application, and that you're within the page limits. So that was a very brief version of the Grants 101. But I think the other thing that I do want to highlight just before Chris comes is that for every grant, or for most of the grants I should say, there is a technical assistance session that comes alongside with that grant that really provides an opportunity for you to meet with that funder that's announcing that grant, and you can ask all the technical and questions, and that's usually early in the application process. I'd encourage you to either attend those sessions or look at the replays of those sessions. They're usually made available online because they really will give you more details about the program, questions that you may have or others may have when considering applying for those HRSA grants. And so certainly you may be a partner on a grant, you may not be the lead writer, but even then it's helpful for you to know what that application is asking for. So I'll turn it over to Chris to wrap us up with some resources.
Did you want to say about the simplified writing?
No.
Yeah, there's a new process coming out in HHS to make the grants easier to read, easier to understand. We'll see how that goes because we are the government, right? So HRSA resources. I'm sorry, I gotta get this connected. So this is, we're really in the QR codes all of a sudden. For someone who's 51, these are really difficult for me. So I always use Google. But HRSA has, these funding opportunities that are available. And if you use this QR code, it takes you to the ones that are directly related to the Maternal Child Health Bureau funding. I'm going to try to go slowly so you guys have a chance. But these are two grants that are currently forecasted for HRSA. Now, if they're forecasted, it doesn't guarantee that it's going to happen. It's going to be posted. But these are two that I have a pretty good feeling that are going to happen. One is around growing and diversifying the doula workforce. And these are community awards, so it can be a community organization. It doesn't you don't have to be like a part of a university or a part of like a health department. These are for those people who work, in the field on the ground. So really pay attention to that. There's also related to that doula workforce program. They're looking for one organization in the country to kind of be the consortium for those who are going to get this award. So I didn't put that on here, but that's another option. Let them be from Virginia. I mean, why not, right? So that's another opportunity that's going to be coming out, also forecasted for like July 2024, summer 2024. The second one is the Building Optimal Outcomes for Moms program. It's a Bloom, is what they're calling it. And again, look at that. There's 20 awards for $40 million. And again, that's supposed to be released in 2024. This one's been forecasted for a couple years, and it just never kind of got the push. But with this year being, we're so heavily focused on maternal health, and our administrator Carolyn Johnson is so focused on this that I'm really hoping that it comes out. So that's another one to kind of consider, to pay attention to. And then there's also other grants out there that come in from maternal health and all of our other programs. So okay, so we just got this email last week. Again, Black Maternal Health Week starts on the 11th, it's 2 days from now. HRSA has a social media campaign that they're offering. It's all free. You just go on there. There's different kind of there's resources, there's different taglines, there's graphic images, there's newsletter copy. This is all for you to use if you choose to. So again, we're trying to get the word out about this, and we're trying to make it easier for you. This is something I was so happy to hear you guys talking about this morning about the National Maternal Mental Health Hotline. This is another item that's funded through HRSA. On that table in the back there, I do have a bunch of cards. You can take a whole pack. If you work like at a health center or a hospital, take them, give them out. They also offer them for these for free. If you go on to HRSA, just Google HRSA, Maternal Mental Health Hotline resources. You can just type your address in, and they'll mail you a box. It takes about 3 weeks. And that includes these really nice magnets that you can put like on a filing cabinet in your office. But again, please, just clear off that whole table back there. There's some in Spanish, and then there's some in English as well. So please take advantage of this. As Alexi had mentioned this morning, it really touched my heart because I had a similar situation where I had my first child. I had infertility issues for 4 years, finally got pregnant, had my son, and then was like, why did I do this? Like, I just had no connection. So I understood what that postpartum felt like. But ironically, for years before that, I was part of a postpartum committee at my work, and I just never made the connection. I just thought I was like just not a good mom, and why did I do this to myself? But luckily, my village came around and helped me and supported me and got me, the medication and the therapy that I needed, and I kind of came out of that and was able to bond with them finally. But it made me sad, so whenever I hear someone's having a baby, I always quietly talk to them afterwards and just see how they're kind of feeling about it. Because it happens. It 100% happens. And so I'm grateful that this line is now available. And you don't have to just be the person, the pregnant person or the mom. A friend, a family member can also call this line if they're looking for some help. So here's a really great resource. It's the Maternal Health Learning and Innovation Center. There's a lot of great material on this website that would probably help you. It's a lot of state maternal mortality level data. There's just so much on here. It's a great place to start if you're doing any kind of research or need any kind of data. The next, on that website, they actually developed, it's called the Practical Playbook 3, Working Together to Improve Maternal Health. You can actually buy this, but there's a PDF you can download on that site to read about different some information. It talks about different people's journeys around maternal health, especially around women of color and birthing people and different populations. So I've heard great things about it. I've only just started it, so I can't tell you much more, but
that's another option. Here's some other resources that we have, a lot around rural health. The RHI Hub is a really great place to go for a lot of great information. And then, again, these are all different rural health resources that are available through HRSA. We have a lot of different training centers and research centers, and that I just want people to know about, just to make it easier for you. And this is a rural maternal health toolkit that just came out of the RHI Hub that has a lot of different areas that might be helpful for you around evaluation and sustainability. I mean, I know there's a ton of toolkits out there, but I've heard really great things about this one, so that's another option. There's also a new rural maternal health webinar series. It actually started last month, so the first 3 are have been recorded and are on the ruralhealthinfo.org website, and then the last one is coming up on the 23rd if you're interested. The next is, these are some other maternal health, again, I said we have a lot of different research centers and areas that could be helpful. I think they're giving out the slides on a PDF of the slides, is that correct? Yes, you'll be getting a PDF of the slides, so you'll have all these links. But the one I want to actually talk about right now is the MCH Navigator. This provides different continuing education credits for people around maternal health with a maternal health focus. And it also helps students kind of decide where they want to go in this space. So that's, if there's only one that you look at, that's a really great one to take a look at. I've also heard a lot of you talk about the Virginia Neonatal Perinatal Collaborative. Our office is actually, for the past couple years, has been convening the regional PQCs, or perinatal quality collaboratives, from our states in our region, as well as Region 2, which is New York, New Jersey, and Puerto Rico. So we get together about quarterly and we kind of share resources, gives them a chance to talk to one another. You know, Shannon Purcell with the Virginia PQC has been wonderful. They're really a star. And seeing all that they've done is just amazing, and they're so inspiring, and I really appreciate all that they put into it. But this is some of the work that they do, is they work on their AIM bundles, which is another thing that's HRSA funded. And these are the specific areas. So they do these, it's kind of a quick, they go in, they make these changes to for better outcomes for moms. And then they collect the data and they evaluate the data, and it's a way to kind of get through learning about all these different issues in a faster way, because again, we're the government and we're kind of a little slow sometimes, but these are the focus areas that they've been working on. Okay, so this is, again, some of our different links. We have the HRSA Data Center, which is, I'm just kind of starting to learn all about it, because I'm not like a data person, but it's actually really easy, and there's really great people that you can email if you're like me and not great with data, and they'll answer you, and they're just lovely. So these are different areas. There's health center data that's updated every year. There's MCH, the block grant information if you want to learn about that. And then here, this is to find grants. If you're thinking about applying for a grant, and you're like, I wonder if anybody around me does this similar work, you can go on Find Grants, and you can look up currently funded or previously funded grantees that are in your area, and then maybe see there could be a connection for you to work with them in the future, because I'm sure there's always a chance that people are like, oh, I really love to do this, I don't have the capacity. If I had a partner, that would make it so much easier for me. So that's a really great place to go and look, and there's some nice information on there for it as well. And again, I'm almost done, don't worry. Then these are our kind of highlighted websites. We have HRSA.gov, HRSA Grants, Data Warehouse, and then Find a Health Center. And again, if you're like me, just Google HRSA and then whatever you're looking for, and you'll find it, because it's actually, that's how I learn everything. So this is our contact information. I'm, again, Christine Woolslayer, cwoolslayer at HRSA.gov. Once you meet a Woolslayer, you never forget it, because it's such a weird name. And then lovely Rhonda Jackson at HRSA.gov. It's R Jackson at HRSA.gov. And then this is our office website.
And then our last slide is just HRSA.gov. And then we do have it, if you sign up for HRSA e-news, that is like, we all get so many different newsletters. That's the one you sign up for because it comes out twice a month. It's pretty short, but it always has all the newest funding opportunities on it. So that's the one I would sign up for. So you just go to HRSA e-news and just sign up. And then you can follow us on all the socials. I feel like a podcaster when I say that.
And before Chris ended, I did just want to add a couple of things. I saw you taking many pictures of the various QR codes and resources. One of the takeaways that I do just want to reiterate with that is that HRSA has lots of resources, things that have been developed. And we really want to make those things available for everyone to take advantage of and tap into so that it just helps to make the hard work that you're doing, hopefully a little easier. So definitely, I know we talked about, for example, Black Maternal Health Week, and certainly looking, I don't think we have that slide, but I really encourage you to take a look at that page. It has all kinds of videos, testimonials. Oh, there we go. Okay, she's taking it back. So I just wanted to re-put that QR code up. We're just very happy to support that. I looked at that as posters, as media messaging, things that hopefully will lessen the amount of time you can just take it and pop it into your current format. So please do visit that if that's helpful. I also wanted to put in a plug for, we talked about maternal and child health grants that are open. Currently also is the Opioid Impacted Family Support Program that is currently open for application. That's out of our Bureau for Health Workforce, and that's to support the training of paraprofessionals to help families affected by substance use disorders and opioid use disorders. And so you'll see that theme, of course, connected to maternal health as well. So I just wanted to highlight that that was also a grant program that's open and a way to look across the HRSA bureaus and divisions to see perhaps where you can tap into, whether a program says maternal health or not, putting in the work that you do and really looking at an opportunity to get funding support for it. And then the last thing I'll say is you may just have a program, you're not thinking about a HRSA grant, don't want a HRSA grant, but you want to connect with our office. Please do. We're happy to meet you. We're happy to do virtual meetings just to share more about HRSA with you, your staff, your partners, your community partners, whoever you may be working with, to just share what either HRSA is doing or opportunities in your counties or state, and happy to spend time and go through that and share as much of these resources as we can. So just want to say thank you for that time today. I wanted to add those couple pieces. And I know I went through the grant stuff really well. If you want to dig deep, I'm happy at any time. You can call me up. I'll take as much time as you want to go through each of those slides about that notice of funding opportunity and tips and tricks for that as well. Thank you. Yes. Oh. We're getting directions here. Here we go.
Oh, and do we have any questions?
Yes. Oh, sorry.
It's quite all right. I recognize it's a little late in the afternoon, but does anyone have any questions for
I have a
Rhonda
quick
or
question,
Christine?
2 quick questions.
Yes.
If you become a HRSA reviewer, can you still apply for a grant, a different one that you're reviewing?
That is
a
good.
little shaky, but that's a question.
Right, that's a good question. I believe there is a process, for example, where you may not be able to, where you can't maybe review for those types of grants that your entity would be applying for. So you could have a grant from HRSA, but you won't review the grant that you would be applying for as an entity. Those types of things. So there are controls and some ethics and some things that are involved in that. But if you're a HRSA grantee, that doesn't preclude you from being a reviewer for other pieces of HRSA.
The other question I have is I send a lot of young people who want to become nurse to your sites because your scholarship program is great. And I like the fact that after they finish, they have to work 2 years in a community health center. Do you have within that program is geared towards maternal health or anything like that? If someone wants to become a nurse, since we're trying to really get this out.
So we have a variety of nursing programs in different areas. So I want to make sure I'm understanding your question. So I think in terms of the broader nursing curriculum, there are certain programs that address that across the board. I'm not sure that they're specifically MCH focused. However, there are programs that support the broad spectrum of nursing and learning nursing. So there's also, I'm trying to think, there's programs at MCHB and schools of public health and other areas as well that support sharing specifically information about maternal and child health. So I appreciate and thank you for promoting those nursing programs, because we definitely want people to take advantage of that, the loan repayment and the scholarship programs that are often open and available for opportunities. So thank you for sharing that. And I also want to share in our regional office, we have our Bureau of Health Workforce Division of Regional Operations that works with those programs, the placements of clinicians, paraprofessionals, nursing, all of those things for those programs. So if you have questions about those, we're happy to connect you with them as well for more information.
Great, thank you.
Yes.
They sit next to me.
Any other questions? I do have a question.
Yes.
Oh, no.
So my question is, to be a grant reviewer, if people are interested, you gave the information, how long should they wait, or what's the turnaround time before they hear? It depends on the need.
Yes, the first step will be to register with the site. So if you go into the HRSA .gov page, and under that finds grant, there'll be a section for a grant reviewer. There's a process by which you register for the reviewer site. There's a whole module. You have to put in your credentials, resumes, things like that. And then that's what's used to pick experts from the field for different panels. So it could depend on the number of panels that are coming up. It could depend on the grants that are out. It could depend on your expertise in terms of how you'll be selected. So the timeline varies. So I can't say you'll get a call in a couple weeks, but you will know that you've been entered into the database and eligible as a reviewer once you go through that process. And as mentioned before, there's some, conflict of interest and things like that you have to go through, and trainings that they do. So it could take a little time, but I think if you're interested in it, the takeaway I would say is get registered and get your credentials in that system, because we want to hear your feedback and have your influence on those grants.
And then my next question is, what is the average amount of the stipend?
Yes, that is a good question that I don't, you're right, that's good, and I don't have the exact figure, so I'm going to have to I'm going to get back to you, but that is a good question, because I think it depends on the program, the number of grants you're reviewing, because that can also vary, and the amount of time and all of that, so I'd have to get back to you with a figure, but I can say there is a stipend, if that's still some incentive for now.
I think it's decent. Pretty decent.
What's decent?
I don't know.
Christine says it's decent, but decent can mean a lot of different things. So, any other questions for our HRSA team? I will say, having worked with Rhonda and Christine for the past several years in our Philadelphia regional office, they are very good, as you know, at what they do. And Rhonda does our grant workshops for not just faith-based organizations and community-based meetings like this. She also does them for our tribal regional offices and our tribal leaders. So if you have any questions with regards to grants, please feel free to take their personal information, get back to them, reach out to them, and if they don't know the information now, they will certainly be able to connect you to the resource or find the answer for you. With that being stated, let's give them one more round of applause. We are into the home stretch here, so we have a quick break. There is Cobbler over on the left if you want that. Water, go use the restroom facilities, and then we'll come back for our next presenter, Dr. Lisa Price-Stevens. And by the way, did you enjoy the breakfast this morning? Did you enjoy the lunch and the selection? Please, let's give Greater Peninsula Cares a round of applause. They are responsible for making sure that this particular convening had what you needed, and we really appreciate everything that they do. So to Bishop Riddick and his team at Greater Peninsula Cares, thank you very much. Okay, good afternoon, everyone. Come on, good afternoon. All right, all right. So we've had lunch, you've had a little bit of snack. Hopefully you had water, used the facilities. We're now moving on to our next speaker. It gives me great pleasure to introduce the Chief Medical Officer for DMAS, the Virginia Department of Medical Assistance Services, Dr. Lisa Price Stevens. She's a native of Virginia Beach, Virginia. She graduated with honors with a Bachelor of Science degree in biochemistry from Spelman College in Atlanta, another HBCU. And then she attended medical school at the Virginia Commonwealth University Medical College of Virginia. She obtained her master's in public health from Walden University and a master's of business administration at Anna Maria College in Paxton, Massachusetts. She's passionate about leadership development and collaborative teamwork. She is a trained and credentialed leadership coach where she utilizes these skills to support individuals and teams to achieve peak performance. During her career, she has led teams in implementing cost-saving ER diversion programs and launched 2 MLTSS plans, I'm sure she can tell me what that means, and developed reverse integration and collaboration care models with primary care, behavioral health, pharmacy, and social work teams. Needless to say, she brings a breadth of knowledge, a lot of experience with regards to her work, and look forward to hearing from her and what DMAS is doing in the Medicaid space. So please join me in welcoming Dr. Lisa Price Stevens.
from my predecessors that I should do a check on how we move the slides. They said down is up. We're going down. Okay, let's see. So now how do you go back? Okay, I'll go there. All right, good afternoon, everyone. Okay, so we're going to do an exercise because I know it's 2:45, almost 3 o'clock. So what we're going to do is we're going to give 3 rounds of applause, okay? The first round of applause is for Melissa Hurd, not Missy, but Melissa Hurd and her team. Yay! All right. Then the third round of applause we're going to give to the AV team in Gethsemane Baptist Church. Heads up. Woo-hoo! That's the second. The third one is going to be to, and I think I have mixed feelings about this, but Bowman Soul in the Wall Peach Cobbler. Woo-hoo! And the apple cobbler. So this was all just, this was an exercise in me trying to make sure you're awake, taking the blood from your stomach, ingesting all of that peach and apple cobbler and bringing it to your brain. So I hope you're up. And if that doesn't work, I just want you to know that Melissa has all of your keys to your brand new car that's sitting outside this door for staying to the end of this program. So stick around. There's always something to win. So I want to say greetings to our visitors. I know there's a lot of people here who are not from Virginia. So if no one has told you yet, welcome to Virginia. Virginia is for lovers. We are passionate and we love what we do and who we are. I also bring greetings from our Secretary of Health and Human Resources, Secretary John Littell, from our Virginia Medicaid Agency Director, Cheryl Roberts, and Dr. Karen Shelton, our Virginia Department of Health Commissioner. So I offer greetings in this way because we are aligned and working in lockstep when it comes to matters of maternal health. This is a key area of priority for the Commonwealth. So today we have had an amazing convening of community faith leaders, providers, our local and federal officials, and many other agencies, all passionate and dedicated to the well-being of mothers and their children. Let's see if this works. So I have data and information regarding the maternal state of affairs for Virginia. That was my charge given to me today. But before I start, I want to share a story. We talked a lot about data, and I'm going to show you a whole lot of data today. But someone said it best, the data really represents people, those people behind those numbers. And I just want to share an experience that I've had with maternal health. So this is a story about a young African-American woman from Hampton Roads area, Virginia. The year was 1966. She was married with 3 loving children and 1 on the way. The entire family was excited, for she was the only of 2 siblings that was able to have children. Her sister had several miscarriages, and it appeared that likely she would not be a mother. On the day of the delivery, everything was going well. She considered herself fortunate to have given birth to her previous 3 children in a hospital with well-respected and competent staff. She delivered her beautiful baby girl without complication until she began bleeding profusely several hours after the delivery. To make a long and painful story short, despite the greatest efforts, the medical team could not stop the bleeding, and she died in her sister's arms, who could never shake the guilt or the imagery of being a nurse herself and not being able to save her sister. She also did not realize at the time that she was pregnant, and the fear of what would happen to her plagued the family, a family that was never the same after the death of a wife, mother, sister, daughter, friend, and aunt. Yes, you see, that was my aunt that succumbed to the consequences of childbirth, and I was that unborn child who for all of my life heard the story and the pain that passed down from generation to generation. When there's a maternal death, the entire family, the entire community is impacted. So in 1966, we were not looking at the data in the same manner of which we look at it today. However, there were some known facts. So in 1966, maternal health was a critical concern, and efforts were made to improve the well-being of expectant mothers. During this period, Children's Bureau played a pivotal role in promoting the health and social welfare of children. Some of those key initiatives were maternal care, focusing on providing quality care for pregnant women. There was a focus on child health, addressing child health issues such as vaccinations. There was a family planning division advocating for family planning services and education. And there was also a child abuse prevention program, initiatives to protect children from abuse and neglect. Now, doesn't that all sound familiar? During the 1960s, maternal mortality rates were notably higher than they are today. Of course, advances in medical technology played a crucial role in driving down the maternal mortality during that period. Virginia, like the rest of the country, witnessed a decline in maternal mortality during the 20th century. Today, we've talked about convening and aligning and collaborating on the issue at hand. But it's also important that we line on how we look at the facts and what we're actually solving for. As faith leaders, community providers, influencers, it's key to fully understand the problem, stay curious, and open to understanding the root cause. Unlike in the 1960s, we now have improved classifications of maternal mortality, and I'd like to talk about that. The term maternal mortality can mean different things, so it's important to know how maternal mortality is defined and measured. And someone touched on this earlier today, but I want to just go a little bit deeper. There are three common terms used when we talk about maternal mortality. There's pregnancy-associated mortality, and that refers to all deaths from any cause that occurred during a pregnancy and up to 1 year after the end of the pregnancy, regardless of the pregnancy outcome. There's also pregnancy-related mortality, and that's a subset of pregnancy-associated death. The Center for Disease Control and Prevention defines a pregnancy-related death as a death during pregnancy or within 1 year of the end of the pregnancy from a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the effects of the pregnancy. A little bit different there. And then there's maternal mortality. It's a subset of pregnancy-related deaths that occurs during pregnancy or within 42 days of the end of pregnancy. The World Health Organization defines a maternal death as a death from any cause related to or aggravated by pregnancy or its management. So when people talk to you about data, pregnancy-associated, pregnancy-related, or is it just pregnancy mortality, it's important for us to understand what that definition means, because it's important as we begin to develop programs to solve for it that we're all talking the same language. So how we look at and interpret the data matters. So for example, when we talk about maternal mortality, when compared with other industrialized countries, the U.S. has much higher rates of maternal mortality. We've said that several times today. You've seen this data. When we look at our state data for Virginia, we often compare ourselves to the national data. However, I just want to offer that maybe we should not be comparing ourselves to the national data and that we need to look at other benchmarks for success. Also, when we talk about pregnancy-related mortality, we see the trends are increasing nationally and for Virginia. When we talk about trends in pregnancy-associated mortality, pregnancy deaths here have shown fluctuation throughout the years, but I cannot help but to notice the spike in 2020. What do you think that was? What did you say? All right, absolutely, COVID. Studies from Virginia Commonwealth University showed that Black and Latina women in Virginia required hospitalizations at higher rates for pregnancy-associated COVID-19 infection than white women, highlighting that the notion that race and ethnicity are an independent predictor of morbidity in this population. In Virginia, and likely throughout the U.S., there are pockets of great concern geographically. When looking at pregnancy-associated mortality by health district, we see that certain areas of the Commonwealth have higher rates. So we see areas in the Eastern Shore, someone mentioned that today, and also in Allegheny. We're not only concerned about maternal care based on geography, but also based on race and ethnicity. I mentioned how COVID-19 impacted maternal care, but really, in our data going back to 2018, before COVID, we can still see disparities. The graph on the left shows the percent of cases by racial groups. However, while the majority of pregnancy-associated mortality cases are highest among the white population, more people, higher association, but if you look on the right, The burden in the recent years is higher among Black birthing populations who are dying at more than 2 times the rate compared with white populations. We've heard that several times, and I hope that you will take this information and quote it back and share when you go out into your communities. So what is happening in Virginia with pregnancy-associated mortality? The data has shown us that the leading cause of death for pregnancy-associated mortality in Virginia, and this is data from 2021, was cardiac conditions, accidental overdose, COVID-19, homicide, and infection. So as you look at this data, I'm sure you're probably thinking, how can I make a difference? Well, the next slide may be able to help you. Nearly 23% of cases had at least one community-related contributor. That means there was influence from the neighborhood or community environment or the services that were unavailable. Over 54% of the cases that contributed to the mortality in 2018 had at least one provider-related contributor. That means inadequate assessment of the risk or delay in or lack of diagnosis. We heard a story about that earlier today. Nearly 29% of all cases had at least one facility-related factors. Inadequately trained personnel is one example. But how about this? 100% of the cases had at least one patient-related factor. That means the patient may have had a chronic medical illness, had substance abuse, or delay or failure in seeking care. Patient-related contributors to mortality often reflect other factors. You know that. There's social determinants of health. There's multiple life stressors, or just a lack of knowledge and understanding of the importance of prenatal care. I can right now, you should see yourselves. I can see light bulbs just going off everywhere. And I can see the wheels are turning because you're thinking about, how can I make a difference with what I do? So I say, let the data lead you. It's becoming more clear that everyone can be a part of improving maternal care, no matter who you are, no matter what your profession is. And as we talked about it, the data shows that 83% of the maternal-associated deaths were preventable. So yes, there is a place for you, and there's something that you can do. So now I'm going to talk a little bit about maternal outcomes in Virginia. I would like to highlight some of our outcome data and some of the things we're doing to make a difference. So the Virginia Department of Health and DMAS, Virginia Medicaid, have put programs in place to address substance use during pregnancy. In general, trends of maternal opioid use disorder is trending downwards, as you can see the graph to your left, mirroring trends in neonatal absence syndrome. However, geographic disparities exist. For instance, in the southwest area of the region, they're experiencing higher rates of maternal opioid use and NAS compared to other areas in the Commonwealth. So if you live in that area and you're wondering what you can do, this is something to consider. There's also a term that's called severe maternal morbidity. We talked about that earlier. Severe maternal morbidity is a collection of life-threatening illnesses and systemic complications that occur during delivery that increase the risk of death during hospitalization. Virginia is lower than the national average, but still high. We have found that non-Hispanic Black birthing persons continue to experience higher rates of severe maternal morbidity as a trend seen nationally. Thankfully, many of our hospitals and health systems are joining forces to collaborate, such as today's convening. But if you're a hospital or health system, you may ask yourself, what can I do? Consider what the data shows. Also, there is severe maternal morbidity in the terms of eclampsia. So for those of you who have heard the term but don't really quite know what that is, it's the onset of seizures from elevated blood pressure and its consequences. It is a condition that can lead to maternal death, and in general, eclampsia has fallen over the last few years. However, gestational hypertension and preeclampsia, which is a hypertensive disorder of pregnancy, both of which may carry high risk for developing eclampsia, continue to rise. So this is a call to action to bring awareness of risk factors and pre-existing conditions that a woman may have prior to becoming pregnant. As you recall, from the 2018 Virginia data, the patient risk contributors to patient-associated mortality were 100% preventable. 100% preventable. So I wonder and hope you are also concerned about how bias, discrimination, and racism are still impacting maternal care. Sorry. I don't know if you've heard about the PRAMS study. That stands for Pregnancy Risk Assessment Monitoring. It's a surveillance project conducted by the CDC in collaboration with health departments, so Virginia participates. The PRAMS collected population-based data on maternal attitudes and experiences before, during, and shortly after pregnancy. The data in the graph represents this question that I found very interesting. The question is stated, during the 12 months before your new baby was born, did you experience discrimination, harassment, or were you made to feel inferior because of the things listed below? And the choices were because of race, ethnicity, or culture, insurance or Medicaid status, my weight, or my marital status. Respondents report experiencing discrimination when it comes to their race, ethnicity, culture, and their weight. In particular, discrimination has been found to be associated with poor mental health and also poor physical health. So you ask yourself, what can I do? What does the data show? Think about how you can make a difference. As a key factor for maternal mortality and morbidity, it is important to understand that experiences of racial discrimination, particularly in the healthcare setting, and how it impacts a person's pregnancy journey and also their postpartum journey. I love when we talked about implicit bias in programs and surveys and ways that we can educate providers. I think we should lean into that and ask yourself, what can I do where I work and what I do and where I work and where I influence maternal health? How can I make a difference in avoiding implicit bias? One of the things that we talked about today was prenatal care. And we are proud that the majority of births in Virginia receive prenatal care early in their first trimester, and it's higher than what is seen nationally, but we talked about that benchmark already. However, receiving prenatal care late or not at all varies by locality in Virginia. So if you look at here, the darker shaded areas have higher prevalence of late or no prenatal care. I'm just highlighting here the dark areas, which is Southwest Virginia. So there's a lot to be done, particularly in the area where access to care is a concern. When we look at availability of providers, we are closely looking at access to OBs, birthing hospitals, midwives, doulas, and prenatal mental health providers. We know that access to these type of providers are lacking, particularly in rural parts of the state. And also there's a concern with representation in communities of colors, and we talked a lot about that today. We know that social determinants of health, such as access to housing, substance use disorder treatment, and transportation, employment play a key role. Someone mentioned this today, earlier, and that is maternal deserts or maternity deserts. The term maternal desert refers to an area where mothers in a specific census tract must drive over 30 minutes to access OBGYN services. A correlation exists between limited access to maternity care and increased likelihood of high-risk outcomes. If you look in Virginia, you can see where our maternity deserts are. Travel times less than 30 minutes drive to obstetric care were associated with lower prevalence of lower birth weight infants across different ethnic and racial groups in the Commonwealth. So otherwise said, it didn't make a difference what your socioeconomic status was. If you had closer access to care, you had better outcomes. Now, travel times may be influenced by structural factors such as historical redlining. I think one of our speakers used that term I hadn't heard in a long time, redlining, and how the effects of poor birth outcomes among Black birthing populations are impacted because of these social structures that are in place and contribute to racial disparities. So when you ask yourself, what can you do from where you're seated and where you work, think about what the data shows. So that's what we're doing today. We're linking communities, we're linking health systems, providers we're linking all of us who have this common goal of improving maternal health. So I'm encouraged by the events that occurred today and the programs that we talked about. And I'm encouraged for not only Virginia, but for our entire region and entire state. I've also been encouraged by some of the programs that are underway now. So the Virginia Department of Health is partnering with Huddle Up Moms, a community-based organization, to establish Moms Under Pressure program. This focuses on areas with the highest hypertension prevalence rates. Moms Under Pressure is a self-monitoring blood pressure program for pregnant women. So these moms will participate and will receive a blood pressure cuff and educational materials. It's the little things like that that make a difference, and I just give kudos to that whole program. When you think about your area, if you do not have a Moms Under Pressure type program, that's something that you may consider. This is what you can do from where you're seated. We also did a lot of talk about the doulas. I'm so proud of how Virginia Medicaid have supported the doula program, and I know that there's so much more that we can do. And it's already been mentioned, but I'll say it again. To date, there are 130 doulas who have been state certified. Of those, 101 doulas are Medicaid approved to provide services to Medicaid members, and there have been 168 doulas assisted births in Medicaid members thus far. So we are very proud of that accomplishment. Also, something you may not know much about is our home visiting program. Home visiting is a proven prevention strategy to deliver family-strengthening services to children and families. And I really like this term, family-strengthening services. We talked about paternal care and making sure the father is a part of the equation in the picture for great outcomes. Home visiting leads to better maternal and child health, less child maltreatment, and increased school readiness, among other benefits. So this is a program that keeps going and giving, and we have benefits way beyond the postpartum period. Home visiting programs are loaded in several communities around our state. And then lastly, I just mentioned a few programs, but there's so many. So this pictorial is just a way to describe some of the great things that are happening in Virginia. We have things like extended postpartum. I think someone mentioned that Virginia was the first state to extend the postpartum period. We have great programs such as Urban Baby Beginnings and Birth in Color. VDH is doing several programs, including developing a strategic plan, which I think you should insert yourself in. You have health departments, you know your legislators. Insert yourself in these programs as you think about what can be done in your community. We're working as a region across agencies and communities to make a difference in maternal health. And I thank you for all that you do. But in closing, I want to tell you another story. I recently attended the Central Virginia American Heart Association Go Red Luncheon. I happened to be seated next to a lovely African-American lady. She was very vibrant and talkative and just full of so much life. As a guest, I assumed that she also was attending as a representative for her organization, like I was. But it was to my surprise when her name was called and she was summoned to the podium. The vibrant young lady, her name was Jasmine, began to share her story of being a young mother of 3, and after the birth of her youngest child, she went home with her husband and had all the support systems you could ever imagine. However, she began to experience leg swelling that persisted and advanced to shortness of breath, and eventually she was unable to take care of her newborn. Of course, she was given all the advice of what she should do, Epsom salt and everything, but she said, you know what, I'm going to call my provider because we're close and I can always talk to my provider. So she contacted her provider, who immediately was responsive and also had her come in to be evaluated. To shorten the story, Jasmine experienced 2 heart attacks and underwent open heart surgery after her second heart attack. Her survival speaks to improved medical technology, but also it speaks to an engaged mother and also a responsive provider and access to care. I was touched by her story. After she gave her speech, there was not a dry eye in the house, but I could not help to think about my aunt. But then I felt better because I thought about my young daughter, and that because of the programs that we have in place, hopefully she will not have to suffer the maternal outcomes of many others. I'm grateful for all that you do, and I ask you to continue the good fight. Don't give up. When things seem discouraging, think about the data and think about how you can insert yourself. And most of all, welcome to Virginia. Are there any questions? Thank you.
I have a question. I'm sorry. So I was looking at a couple of your slides, and I just want to make sure that I understood where you had the map of the maternal deserts. And
I can go back to that.
okay, great.
I think.
Yes, thank you. Oh, no, the one
Yep.
two before. Okay, so this is the map of the maternal care deserts. I'm not familiar enough with Virginia, but you said the southwest.
So where you see the darker shades are where the desert areas are.
Okay, and then if you go to the other slide where there was a lot of blue home visiting, is that because there is more robust home visiting care programs in that state that section because there's no
Exactly. I love when people connect the dots, you know? I like to overlap our heat maps because you see the area of need, and that's exactly what I wanted everyone to do, to say, wait a minute, I live in that area. I think that's what I need to do, or I know folks in that area. So yes, we're trying programs in areas of need. Not saying that they can't go statewide, but usually when you start a new program, you want to start in one area, have proof of concept, and then move on. So that is the correlation of that.
Okay. And then my other question is, what's the reason for the deserts? Is it, I know there are hospitals that are closing, but is it just the hospitals? Is it hospitals and perhaps population moving? What's the cause?
So who here is from Southwest Virginia? Maybe see, that's one reason. It's far.
That's what I said. That's what I was going to say. It's not just the hospitals. It's something else. It's because no one's there.
We do have hospitals there. We do have hospitals that have been closing. We have providers there. It is just, everything is so far away. We even went there recently and did a program talking about doulas. And the doula was saying, I have to drive 3 hours just to get to my client.
Oh, wow. Okay.
And then drive 3 hours back to try to go to work the next day. So everything is spread out. We need more of the workforce. Just had a discussion with some pharmacists. A lot of small independent pharmacies are there. Mm-hmm. They're struggling there. The Walgreens shut down. I mean, you know, it's just, the area is just so spread out. We definitely need more of everything in that area. And we can get you in the car and take it to Southwest Virginia. You'll know what I'm talking about as soon as we get there. You're like, are we there yet? No, we're still in Virginia.
Thank you.
Thank you. Thank you, everyone.
Okay, we have one more panel, and then we're going to have testimonials. So if I could get some help with the tape. Oh, great. I see individuals coming up. We decided this time on the planning committee to introduce a new segment that wasn't in our Philadelphia convening. And that is, we talk about so much trauma. We talk about the fact that women are experiencing things when they go to their physicians or their provider's office that they shouldn't. They're told that it's all in their head, or the pain is not as great as they think it is. Just go home, everything's going to be fine. And then we started to think, maybe people are just not being treated the way they should be treated as human beings. And why is that? Why are we really digging into the difference between what a person of color feels when they're expecting, as opposed to someone who is Caucasian and what they're experiencing when they are expecting their family, because it's not just the individual, it's the whole family. And so what we wanted to do with this particular convening, again, that we didn't do in Philadelphia, was take some lessons and sort of think about civil rights and what people are experiencing when they go to their providers. Now, in this space, we're talking about maternal health, But it could be any number of things where you go to a provider and you are not receiving the care that you know you should be receiving, and it's based solely on the color of your skin. So it's my pleasure to right now introduce Deborah Kolodner and Chelsea Kimball, who are both principal investigators for our Office for Civil Rights in the Philadelphia Regional Office, to talk about what they do and if there are any resources that could be of assistance to the people and the communities you serve. Thank you.
All right. Oh, okay. It's loud. All right. Good morning, everyone. Oh. Good afternoon, everyone.
It hasn't been a long day.
So we're at the home stretch. As Melissa had introduced, we're from the U.S. Department of Health and Human Services, Office for Civil Rights, HHS, OCR for short. So we're here today to talk about civil rights in healthcare, specifically addressing maternal health. My name is Chelsea Kimball. I'm an investigator with OCR, and this is my colleague.
Good afternoon. I'm Deborah Kolodner. I just want to interject before we start with our planned presentation. I just feel blessed to be here today to deepen our understanding of the issues and the solutions and the work in the field that you all are doing. We are also grateful to share with you all about the work of the Office for Civil Rights and the protections afforded by the law, that it's important for everyone to be aware of those protections. And now Chelsea will lead us.
All right. Okay, perfect. So today's agenda, as you all know, health disparities is a complex topic with a multitude of contributing factors. This presentation will focus on one important contributing factor, which is race, color, and national origin discrimination, as well as how compliance with civil rights legal authorities is one way to help reduce healthcare disparities. Today, we will primarily talk about two federal civil rights laws, which is Title VI of the Civil Rights Act of 1964 and Section 1557 of the Affordable Care Act, and how these two laws apply in reducing maternal health disparities. The purpose of this presentation is for you to, one, know about how OCR and applicable civil rights laws apply, understand the latest information regarding maternal health disparities, and three, understand civil rights obligations and how to identify potential discrimination, and know how to file a complaint with OCR so we can employ our resources to help reduce health disparities. So in this first section of our presentation, we're going to briefly go over, what OCR is, what laws we enforce, and who exactly is covered by said laws. All right. So what is OCR? OCR enforces federal civil rights laws for HHS through investigating complaints from the public, initiating compliance reviews, securing voluntary corrective action, providing technical assistance, conducting public outreach like today, and issuing regulations and guidance. Additionally, OCR has guidance available to help individuals understand their civil rights and to help covered entities comply with their obligations under the law. So, what laws does OCR enforce? So we enforce a lot of laws. On the screen is a highlight of are most frequently used laws. This includes Title VI of the Civil Rights Act of 1964, which we're going to discuss later, Title IX of the Education Amendments Act of 1972, Section 504 of the Rehabilitation Act of 1973, the Age Discrimination Act of 1975, Title II of the American Disabilities Act of 1990, and Section 1557 of the Affordable Care Act. So, who is covered by the laws that OCR enforces? So, public and private organizations and individual service providers that receive Medicare, Medicaid, and state children's health insurance programs, any organizations that receive temporary assistance to needy families, TANF, and any organizations that receive other federal funding as well. OCR also enforces laws against covered entities that are state and local government agencies that provide health and social services. This includes hospitals, clinics, managed care organization, Head Start programs, nursing homes, senior centers, and so much more. So in this section of our presentation, we're going to turn our attention to Title VI, as well as Section 1557 and their role in civil rights in the healthcare. Now, how does Title VI and 1557 apply in the delivery of non-discriminatory services? So, discrimination against persons because of their race, color, or national origin is contributing to this ongoing issue with healthcare disparities. Providers can help to reduce healthcare disparities simply by understanding and complying with their Title VI and Section 1557 obligations to provide equal access to their services regardless of race, color, and again, national origin. So before we talk in depth about health disparities and maternal specifically, in today's section of the presentation, we're going to talk about how compliance with civil rights laws helps to reduce healthcare disparities. So much of the healthcare disparities that exist today are both from a lingering effect of widespread segregation and ongoing racism and discrimination. You might not be aware that before Title VI, federal law under the Tim Burton Act specifically allowed federally funding to flow to racially segregated hospitals until 1963. That's when the Simpkins versus Moses hospital case came about. In Simpkins, the U.S. Court of Appeals of the Fourth Circuit ended up holding that hospitals that were accepting the Hill-Burton funds were instruments of the state. Therefore, the Act's separate but equal provision was unconstitutional under the 14th Amendment. All right. And that segues into what we have today, which is Title VI of the Civil Rights Act of 1964. So Title VI of the Civil Rights Act states that no person in the United States shall, on the basis of race, color, or national origin, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. Title VI prohibited and still prohibits the flow of federal funds to any entity that discriminates on the basis of race, color, or national origin, which includes nearly every hospital in America that receives Medicare or Medicaid. And who does Title VI exactly protect? Essentially, Title VI protects people in the U.S., people of all races, people from any nation, birthplace, ethnicity, or ancestry. This also includes people of any immigration or citizen status and people with limited English proficiency, which I'm going to touch on in later slides. All in all, Title VI protects all of you. So what are the Title VI requirements? The concepts in the law in Title VI are responsive to the circumstances in 1964, when Title VI and its implementing regulations were written. At that point in time, the problems were due to racial discrimination, outright denial of services, or provision of services in a different segregated place on the basis of a patient's race, color, or national origin. Discrimination against persons because of the race, color, or national origin continues to contribute to ongoing health disparities that we see today. Providers can help reduce these healthcare disparities, again, by understanding that they must comply with their Title VI obligations and to provide equal access to their services regardless, again, of race, color, and national origin. So as prior speakers have discussed today in this convening, communication is absolutely important. As a provider, you must understand your patient in order for your patient to also understand you. This is why Title VI is so important, especially to those that are pregnant, for example, with limited English proficiencies. This includes understanding that, conduct having a disproportionate effect on persons with LEP, for example, may be an instance of national origin discrimination. Under Title VI, recipients must take reasonable steps to ensure meaningful access to their programs, activities, and services for those that are LEP. Failure to provide individuals with LEP may constitute discrimination. An individual with LEP is a person whose primary language is not English and who has limited ability to read, write, and understand English. Therefore, providers absolutely must provide language access services at no cost where necessary to ensure that persons are not discriminated against. So, when is an interpreter and translated materials required? So, for interpreters, a covered entity should ensure that a competent language service provider for oral communication is used. A competent provider is one that is proficient and communicates accurately in both English and the other language that the person speaks, uses appropriate modes of interpreting, knows specialized terms and concepts in both languages, understands and follows confidentiality and impartiality rules, and understands and adheres to the role of being an interpreter. This is also important that covered entities should not rely on the patient's friends or family to translate for them. For translated materials, it's essentially very similar to the guidelines for interpreters. Translation of written documentation is required to meet effective communication requirements. With oral interpreters, translators of written materials should be competent. Again, many of the same considerations apply for translated materials as you will see for interpreters as well. Now we're going to turn to Section 1557 of the Affordable Care Act, which OCR enforces. Under this act, it prohibits discrimination on the basis of race, color, and national origin, sex, disability, age, in certain healthcare programs or activities. It is the first civil rights act to prohibit sex discrimination in healthcare. It applies civil rights protection to health insurance marketplaces that are established under the Affordable Care Act. Okay, this topic was touched on today by many speakers. We're going to take a closer look at both bias and discrimination as a cause of health disparities. So what is essentially the difference between racial bias and racial biases that amount to discrimination under the law? Beliefs by themselves are not discriminatory. However, if the beliefs affect the quality or quantity of health care provided, then the treatment may amount to discrimination under the law. Essentially, when trust is compromised, the physician may be perceived to not be working in the best interest of the patient. This may lead the patient or the person of a particular race or ethnic community to conclude that essentially the physician's biases adversely affected their patient care. An example of biases that OCR protects is discrimination based on shared ancestry or ethnic characteristics. This means that Title VI protects against not just race, ethnicity, or where a person is from, but also against race, ethnic, or ancestral slurs. Everybody knows it as stereotypes. How a person looks. This includes skin color, facial features, the way a person might dress might reflect their ethnic or religious traditions. And this also includes foreign accents, a foreign name, or even the language that they speak. And now we turn to implicit biases. So again, a lot of people have talked about this today, but implicit biases are also known as unconscious biases. It refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. An implicit bias can make us susceptible to unintentionally acting in ways that are inconsistent with our own individual values. Although you may not choose to have an implicit bias, you can choose to be aware of it and combat its effects. So 2 important steps are to recognize that we all have implicit biases and that implicit bias can negatively affect clinical interactions and outcomes. And 2, we can accept the responsibility to identify and understand our own implicit biases. Some of the strategies that can help to reduce stereotypic thinking is stereotype replacement, counter stereotypic imaging, individuating, that's a hard word, perspective taking, contact, emotional regulation, as well as mindfulness. Consistent and conscious use of some of these strategies can help create a habit of non-biased thinking and help providers to provide the best care that they can to the patient. And Deb's going to talk more about this in her later slides, because HHS does provide a training. It's called Think Cultural Health, and it touches on implicit bias. All right, so I'm going to pass it over to Deb, who's going to handle the next section of this presentation.
Thank you, Chelsea. And Chelsea's going to be doing the clicker for me. So next slide, please. We're going to be delving into a little bit more of the information related to maternal health disparities and the work of OCR. First, we're going to look at the definition of health equity. Equity means the consistent and systematic treatment of all individuals in a fair, just, and impartial manner, including individuals who belong to communities that have been denied such treatment. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and to the elimination of health and healthcare disparities. Conversely, health disparities are the inequalities that occur in the provision of healthcare and access to healthcare because of different characteristics, including but not limited to race, ethnicity, sex, sexual orientation, and gender identity, disability, socioeconomic status, and geographic location. Notably, some of these characteristics are the same as the bases for which federal civil rights laws prohibit discrimination. That would be race, sex, sexual orientation, and gender identity and disability, and some are not, such as socioeconomic status, geographic location. OCR only has jurisdiction to address the health disparities that are a result of discrimination prohibited under federal civil rights law. There are multiple reasons why health disparities exist. Many of these we've discussed today. Some of the reasons include issues that disproportionately impact people of color, including access to healthier food retailers, education and income, unemployment, work-related injuries, and environmental injustice. For example, residential proximity to heavy industry, major highways. And as we've spoken about the maternal health crisis, why is this a crisis? As we've heard today, 84, I don't know if we've heard a data point, but 84.2% of pregnancy-related deaths could have been prevented. Preventability decisions may be documented in two ways: determining preventability as a yes or no, and or two, determining the chance to alter the outcome by using a scale that indicates no chance, some chance, or good chance. Any death with a yes response or a response that there was some chance or a good chance to alter the outcome was considered preventable. Deaths with a no response or a no chance were considered not preventable. And now I'm going to turn it back to Chelsea for a couple of the slides.
Yeah. So again, why is this a crisis? So this table highlights the distribution of pregnancy-related deaths by timing of death in relation to pregnancy. This data is from the Maternal Mortality Review Committee in 36 states, and this was from 2017 to 2019. The table shows that among deaths for timing in relation to pregnancy is known approximately 22% of deaths occurred during pregnancy. 25% occurred on the day of delivery, and this is calculated within 24 hours of the end of pregnancy, or within a week of delivery. 23% occurred from day 7 to day 42 of postpartum, and lastly, 30% occurred in late postpartum period, and this is from day 43 to day 365 of postpartum. Now I have two infographics here. The first infographic on the left is from the CDC data from 2020. It shows again that the United States continues to be an outlier among industrialized nations, with a maternal mortality rate several times higher than other high-income nations. The maternal mortality rate in the U.S. is nearly 3 times of that of France, the country with the next highest rate. The second graph illustrates, again, something that we've talked about today. Black women are 3 times more likely to die from childbirth when in comparison to their white women's their counterparts, and this is within 42 days of being pregnant.
Across the United States, Black women and babies experience worse maternal health outcomes than other racial or ethnic groups. This is true across different socioeconomic levels. The wealthiest Black moms and their babies are twice as likely as the wealthiest white women and their babies. We've heard about other individuals who have been personally impacted by this crisis. One other person that we wanted to mention is tennis star and world-class athlete Serena Williams, who had a pulmonary embolism after giving birth, yet healthcare professionals did not address it at first. Her frightening, life-threatening experience highlights how even the most famous, wealthy, and healthy of Black women cannot escape the risks of discrimination in healthcare. The next slide is data for the 5 states and the District of Columbia in the Mid-Atlantic region. We reviewed the mortality data from the state mortality review teams, briefly reviewed. I'm not a data analyst, and took snippets of the data. And in every state in the region, there is a higher rate, significantly higher rate of maternal mortality for Black women than white women. Just wanted to mention that the state of West Virginia said that they do not have disaggregated racial data, so that they don't have the statistics. And I guess this just points out how we need all of the states to start collecting the data and collecting it in a uniform manner, because it is a little bit, even not as a data person, trying to take the snippets, it was hard to compare one state to the other. Again, the United States is facing a maternal health crisis. Regardless of income or education level, Black women are 3 times as likely to die from pregnancy-related complications. Native American women are more than twice as likely to die, and women who live in rural America, where there are many maternal care deserts, term we've already heard today, are about 60% more likely to die. These outcomes are largely due to systemic inequities, which create significant disparities in how women experience the healthcare system that can often be a matter of life and death. Next slide. And now we'll delve a little more deeply into the issues. And we do have a brief video, this video is an example of how the healthcare system failed.
New data released by
Another bright, successful, talented woman of color. You may have heard about her in the news as well, Dr. Shalon Irving, who worked for the CDC, and she fought for equity in healthcare. And she herself died shortly after giving birth to a daughter.
New data released by the CDC shows Georgia ranks as the worst in the nation for deaths of expectant mothers. The CDC also says Black mothers in Georgia are twice as likely to die due to birthing complications than white mothers. Now, a CDC scientist's postpartum death is the inspiration behind a new tool to help fight racial disparities in this area of healthcare, and it's providing virtual support to Black mothers. People to People's Nicole Carr has the story.
I knew, intellectually, I knew she wasn't coming home, but my heart refused to accept it.
Days turned to months, turned to years, but each afternoon, Wanda Irving stared out of the window, rocked her granddaughter Soleil, and waited for her daughter to return home.
Had they just paid attention, listened to her, believed what she was saying, and even if they had just put her in the hospital for observation.
It's been 4 years since Irving lost her daughter, Dr. Shalon Irving, to complications from childbirth that ended her life 3 weeks postpartum.
She had gold-plated insurance. She worked at the CDC. She was an educated, intelligent, professional woman, but yet and still she was treated as if she were poor, Black, uninsured, and just not one to be believed, valued, or trusted.
Dr. Irving, a 36-year-old CDC epidemiologist and health equity champion, had an overall healthy pregnancy and what her mother calls a textbook delivery, but also took medication for a blood clotting disorder. Her fertility journey included surgery to treat uterine fibroids. Following a C-section delivery, a lump grew in the area of her incision. It was drained but wasn't healing. Her blood pressure spiked, headaches became unbearable, and the swelling in her legs needed attention. She'd gained 9 pounds in 10 days. Each of at least 7 medical visits ended with her being sent home with nothing more than blood clot medication prescription.
And all they did was pat her on the head, and it's like, it's okay, you just had a baby, don't worry about it, it's gonna be all right.
The last ER visit, 21 days after giving birth, ended with doctors telling Irving to take medicine and call days later if she still felt bad. While pumping milk and talking to her mother and looking at her daughter, Dr. Irving passed out in her Sandy Springs home that day. In cardiac arrest, she was brain dead by the time they returned to the hospital.
I will always carry the guilt that I did not say, look, we are not leaving this place until somebody does something for my daughter. But I didn't, and most because Shalon had cautioned me in the past, Mom, don't get upset because I know how you are, and then it's just going to be considered an angry Black woman, and they're not going to do anything. They're just going to probably escort you out of the hospital. So I held my tongue, and I'll have to apologize to her when I see her that I didn't do more.
Today, Wanda Irving raises Soleil in that home. Eventually,
I have to say, after I watched that video, I've watched it a few times now, the one thing that clicks in my mind is the mom saying how her daughter warned her or said, don't say too much because you'll look like an angry Black woman. And I guess to me, that's like a big part of the problem, that if you say too much, you know, you have to hold your tongue, which is a problem. And now let's look at some of the things that can be done to prevent another Dr. Shalon Irving story from occurring. What can we do to improve maternal health outcomes? And listening to the presenters today, it does sound like there is an effort and there are a lot of good things going on, but I guess it's just not enough yet. But what do we need to do? Increase physician diversity and provider awareness. Research shows mortality disparities between Black and white individuals correlate with levels of Black representation in the physician workforce. Only 5.7% of physicians in the United States are Black, but over 12% of the population is Black. It's been shown that Black people who live in counties with more Black primary care doctors live longer. We've talked about increasing the availability of doulas and access to appropriate pre- and postnatal care. And we've also discussed culturally and linguistically appropriate maternal health training. As Chelsea mentioned, HHS does have available a training under Think Cultural Health, and it's a 2-hour e-learning program designed for providers and students seeking knowledge and skills related to cultural competency, cultural humility, person-centered care, and combating implicit bias across the continuum of maternal health care. And OCR is working to improve maternal health outcomes. HHS itself has a long-standing history of working to reduce healthcare disparities and improving equity. OCR has and is continuing to follow HHS's action plan, for example, by conducting the outreach education like today's program. Additionally, OCR initiates compliance reviews and complaint investigations, as we will explain in more detail. Now we'll talk about the complaint process and enforcement. Looking back to earlier part of our presentation where we spoke about Title VI and Section 1557, the remedy provided for by these laws is what I will call an administrative remedy. If an individual believes that a healthcare provider is discriminating based on race or does not provide an interpreter for an individual with LEP, the individual or an advocacy group may file a complaint with OCR. The complaint would be filed against a particular covered entity, such as a hospital or other provider. On the slide, you see the link to the complaint portal on the HHS website, and it's also possible to request a written discrimination complaint package, and they can be submitted to our office. The easiest and fastest way, of course, is going online. Complaints must be filed within 180 days of the alleged act or omission complained of, and OCR may extend the 180-day period if good cause is shown. So if you're filing beyond the 180 days, include a reason for the late filing. Now, what happens once a complaint is filed? OCR expects to receive more than 50,000 complaints this year. So when these complaints come in, initially there's an informal review of the complaints, and they may be resolved without a formal investigation. For example, if OCR doesn't have jurisdiction, if the entity is not receiving federal financial assistance, OCR would not have jurisdiction over the entity. If the complaint was not filed within 180 days, or if the allegations in the complaint do not support a violation of federal civil rights laws enforced by OCR. If the complaint is not closed in that initial process, we contact the complainant, we gather information from the complainant, and then we open an investigation. Once the investigation is open, we contact the covered entity, notify them of the complaint, and ask them to respond to the complaint and provide certain information in response to the allegations. We continue the investigation and then make a determination either that there may not be a violation, or that OCR generally, or what we try to do is seek voluntary compliance or corrective action. And if we are not successful at that, OCR issues a formal finding of violation resulting in formal enforcement. If the violation is not resolved, all federal financial assistance from HHS can be terminated following an administrative hearing, or the matter can be referred to DOJ for enforcement. That, I have to say, is a very rare occurrence that we would terminate federal financial assistance. In addition to investigating complaints, OCR also conducts compliance reviews based on media reports or lawsuits filed on behalf of maternal health patients and other concerns raised by stakeholders. As an example, OCR initiated a compliance review in response to press reports indicating that paramedics refused to transport a pregnant Black woman to the hospital because the EMTs assumed she couldn't afford the ambulance cost, and the patient later died. In response to OCR's review, the ambulance service implemented voluntary corrective action. And what are best practices for covered entities, and what do we look for when we open an investigation? We look to see if the entity has designated a workforce member to serve as a Title VI Civil Rights Compliance Officer. Are all workforce members required to participate in civil rights training that is both organization and job responsibility specific within 30 days of hire and annually? Explore opportunities, again, to partner with doulas. Another action we look for is to reinforce the critical role and responsibility of every workforce member in protecting civil rights. And we look to see if the entity implements, maintains, and publishes a non-discrimination notice in facilities and on its websites with information about filing complaints internally and with OCR, and to see if the entity implements and maintains detailed non-discrimination policies and procedures. And this next slide is resources that are available for further information.
All right, and this slide has our office contact information, has OCR's website, government email, our phone line, and then our address. We know this was a lot of information to digest. I know we're a little behind schedule, so Deb and I do plan to stay after closing. Everything closes. So if anybody has any individual questions that they want to ask us, please feel free to approach either one of us. We do thank you so much for listening in, paying attention, and again, thank you for allowing us to share our knowledge in this space and be amongst all of you. We hope that this was insightful.
Thank you.
Just want to say thank you again to Chelsea and to Deborah for giving us that information. It was a lot of information, but if I could take away a couple of things. First is the graphs that she showed about America, and then the second country was France, and how the red bar for America was so far over to the right, and France was not even a fourth of that. And so it shows a shocking picture. And then the other thing, of course, was the African American women against the white mothers and the Hispanic mothers. So we know the information. We've talked about it. We've heard a lot about it today. But this next section really gets to my why. Why do we do this? We know the information, we know the statistics, we've probably had people who've had experiences, but I just want to take a moment to set the stage that what we're about to hear in terms of testimonials, it really is a sacred space. I just want to pause there and tell you that it's a sacred space because for people to come and share their personal stories, we need to honor that. We need to honor what they've designed by grace to share with us and to keep it. It's not our story to tell, it's their story to tell. And we want to make sure that we're doing so and hearing it with respect. So with that, I'd like to introduce Heather Wilson, who will share her story and also give us additional information about the sacred work that she does in this community. Heather.
Got all my visuals, so I'm trying to put them in order so that I can stay focused and share my story. Thank all of you for staying. I know I'm at the end of the day, and so I just thank you all for staying and for allowing me to share. No matter how many times I share my story, it's still difficult because it's something I live with every day. And I'll start by saying when my journey began. And so I began this journey of working to become a mom in 2009. So by that time I had just finished my master's degree in counseling, and I'd been married for 2 years, and it was time. My husband and I were eager to start our family, and so we did everything we thought was right. We were excited, we planned. By the time it was the end of my pregnancy, we had 3 baby showers because I'm originally from Rhode Island, so we had to have one in Rhode Island, and we had to have one for the work family. And just really preparing for her. It was something we prayed for, and it was an answered prayer when we saw that positive pregnancy test. Literally by the second trimester, I had everything washed and dressed. Her room was painted, her crib, everything was just set in place. And so we were just awaiting the time when Kennedy, as we named her, would come. I had kind of an uneventful pregnancy. There, to me, was never any alarm. We were never really prepped that anything was truly wrong. Around the second trimester, I was told I had preeclampsia, but again, they just said, you have preeclampsia. If you get a headache, let us know. It was never any information told to me that my life or my daughter's life would be in danger. And so we did everything the doctors told us to do. There was nothing, doctor's order, I'm a planner, I keep a planner, I keep a highlighter. If they said to do this, that's what I did because I trusted my doctors. I trusted that they would keep me and my baby safe. So it was around my 36th week, and I had noticed that Kennedy just wasn't moving as much. So I called my husband, he works at the fire department, and I said, she's not moving as much. And he said, "Oh, don't worry. When I get home, I'll have you drink some orange juice. It'll be fine." And so he came home that morning, and we drank orange juice, and she still was just not moving as much. And so he decided to call our doctor, and she instructed us to come to the hospital, just precautionary. So we went to the hospital, and still just thinking it's probably nothing, because no one's alarmed. No one has said preeclampsia could be deadly. No one has said anything aside from just keep coming in for your appointments. Well, we were early for our appointments. We came together as a couple. There was not an appointment that we missed. So went to the hospital, and that's when time started to slow down. We noticed that when they were trying to find her heartbeat, that they were taking a long time. We also noticed that they were bringing in a different machine, or they were, what we eventually learned, they were stalling. They were stalling until a doctor came, because the nurses, of course, could not give us the news that there was no longer a heartbeat. So at 36 weeks, I lost my daughter to placenta abruption. She essentially suffocated inside my belly because of my preeclampsia. And I can promise you that my life and the life of my family has never been the same. There's not a day that we don't yearn for her. There's not a day that we don't remember her. There's not a day that we don't sit and think, what could we have done different? The clip that was just played about the mom saying, "I wish I would have," I still have that. I mean, I've done years of therapy to process this and to get to the point where I can stand in front of an audience and share my story. But it's impossible. I brought a picture of my daughter, because sometimes people don't realize with a stillborn, they're literally perfect babies. There was nothing physically wrong with my baby. My baby didn't have a fighting chance because doctors didn't prepare me. They didn't see me as often as they should have seen me. They failed my daughter, and they failed my family. So this is Kennedy. This was taken before I left the hospital. And I hold tight to this because these are one of the only things that I have of her. I have her baby footprints, and I have the pictures from the hospital, the pictures from the funeral home, and that's it. That's all I have. So when this happened, devastated, just devastated, in shock, guilt, every emotion you can think of. And my husband went into research mode, and I just went into a shell. But I dove into therapy. I dove into how can I help other women, other families. And so that's what I did. I started a nonprofit. It's called Kennedy's Angel Gowns. And the one thing for me, I love fashion, I love clothes, and I dreamed of just big bows in her hair and dressing her in these cute little mommy and me outfits. And so that stuck with me. And so when we tried to bury her, there was nothing small enough. She was 5 pounds. She was small, but not too small, to fit regular size clothing. But there's nothing in the stores that's appropriate for a funeral at that size. Not to mention, after you lose a child, the worst place you could go is into the children's department to look at clothes. So I wanted to fix that. And so what I did was I started with my own wedding dress, and I cut my wedding dress up, and I started to make these burial gowns. I have some random talent from my grandmother that I can sew without patterns, and that's what I began to do. And so I brought some to show you, because these babies are so tiny and so small. So we make them for girls and boys, of course. They come in all different sizes. They are handmade with love. But we also noticed that a lot of families were reaching out for babies that were born really early, like miscarriage age, and so we started to make these swaddles so that they too could hold their babies. And our mission just started to grow and grow, and my husband is huge into research, and so what we were researching is, and what I was seeing is, when I would go bedside, because this has become literally my mission, when I would be bedside, I would say every other mom, if not more, looked just like me. And I noticed that it was Black and brown babies that were dying. And of course, my husband did the research, and this was before it became a popular topic, and it was true. And so for me, that changed what we were doing. Not completely, we still help when there is a need with the angel gowns, but we also started a doula program. So we are training doulas for free. We've had 2 cohorts so far, and we are offering free and discounted services for families that need them. It's been, thank you so much. It's a piece of me giving back. I focus mainly, I don't typically do live births. For me, I am more of a bereavement doula because that's where my heart is, that's what I know, and that's a huge piece of our modules in our doula training class is with bereavement, because it's something that we don't know what to do or what to say, and so we teach that. We teach the support piece, and we help families through it. So that's my organization. I'm going to talk a little bit more about that, but I'd be remiss to not share that my experience this past August. So I was failed again. So in 2009, I lost my daughter, but this past August, I lost an organ. I went to 4 hospitals, 1 in North Carolina and 3 in Virginia, where I was turned away 4 separate times. I was so sick. I can tell you that this was worse than delivering my baby. I have never been so sick. I had a stabbing pain in my side. I kept going back to the hospital and I kept getting turned away. By the 3rd hospital I went to, they literally put a catheter in me and sent me home. They could not tell me what the catheter was for, but they sent me home with it because I was having pain here. There was testing done that showed that I had a cyst on my ovary, but no one paid any attention to that. They just kept sending me home. I went home the 4th time and I told my mom, I literally think I'm dying. I've never felt such bad pain. At this point, I have the catheter hooked up to me. I have my mom putting hot towels on me and 3 separate pills for just opiates that they keep throwing at me. And by the time, it was the 4th day, and it actually happened to be on what would have been Kennedy's 15th birthday. My mom called 911, and she caused that scene that mom is talking about. She caused the scene, and within an hour, I was in surgery getting my ovaries removed because now the blood supply had been cut off because it was 4 days too late. So I have been failed by the medical system multiple times. Like I said, it first cost me my daughter's life and almost mine. And now I've lost my ovaries. Not that we were planning to have more children, but it was just still, it's hard when you're not planning to lose them as young as I am. It was just a hard, it's been a hard walk, especially for me. What was so hard about that is I sit in rooms and I advocate for other women, but I was in so much pain that I could not advocate for myself. So keep that in mind when you're working in these fields, that sometimes even the advocate can't advocate for themselves, because when you're in pain and that pain is at a 10, you can't even speak up for yourself. I knew all the things to say. Of course I did. I do this for other people. But being in pain, I just saw a different side of it, and it was just a realization of how real it was, even present day. So I appreciate all of you for doing the work, for coming to the trainings, for making sure that this fight is not just the folks that have passed away or the families that are affected or the babies that have passed away, that the fight is everyone's. We are screening Aftershock. If you haven't seen it, please come to our screening. It's on May 3rd. It is at the Kroc Center. Omari, he is the spouse of one of the women that died shortly after birth. He will be coming and serving on the panel. And then we have an angel ball on the 4th. It helps us to raise money for funerals for babies, to help with our material, to help with our volunteers. We're a 100% volunteer-based organization. I have a full-time job, and then I have that full-time job. So any help we can get, we love that. This is my passion. It's truly my pain to passion. This has been the most painful thing I've ever been through. But I promise you, when I can be in the position to help another mom walk through this and give her a little glimpse of hope that you will get through this, it's like I'm getting a hug from Kennedy, and I will continue to do this work until I have no breath left in my body. So again, I thank you for letting me share my story. I thank you for your support, and I thank you for continuing the fight. Thank you.
I certainly want to thank Heather and thank Kennedy's mom for sharing. And we have one other testimonial that we'd like to show you at this time.
My name is Michelle Simmons, and I was diagnosed with postpartum preeclampsia a week after giving birth.
So it was Valentine's Day, and I was doing some work at the table, and she came and dropped the test on the table. I looked at it, and we both just started smiling. That was basically my Valentine's Day gift when she opened some gifts she had got and said, "Daddy of a princess." So then I knew when I saw that it was a little girl.
Throughout the whole pregnancy, everything looked normal.
I would say it all went wrong when the doctor told her she wasn't dilating. And then after that, they said the next morning they're going to go ahead and do the C-section. And Michelle got really nervous. I've never seen her this nervous before. The doctor said the baby's not moving. So my first thought is, something's wrong with the baby. Maybe her heart stopped. Everything was going through my head. Any and everything. The cord was actually wrapped around her neck, and we didn't know. We were home for about a week and a half. Michelle said she wasn't feeling right.
My husband and I returned to the hospital. At that time, I was treated, but then later diagnosed with postpartum preeclampsia, which was really a relatively new term to me. I had heard about preeclampsia in pregnancy, and then once you deliver, it resolves itself, but I'd never heard about postpartum as much. So I was sent home with probably about 10 medications and things to do. I was told if I had some swelling, or I was having headaches, or I felt faint, or was seeing spots, that I needed to return immediately. I was told to begin to check my blood pressure daily, multiple times a day, and if it was over 160 over 90, then I needed to return to the emergency room. So it really, mostly that first go round, involved a lot of medicine, I would say, to try to treat the situation. And then unfortunately it was not eradicated that first go round, and I ended up back in the hospital the next week after returning home.
She said, "My baby's not going to recognize me when I get home." She said she's going to think my mom is her mom, because it had been that long that we had been in there. So that was kind of a tearjerker when she had said that.
It's unfortunate that Black women are dying at the rates that they are just to bring life into this world, which is so beautiful. How can something so beautiful be such a chaotic, sad moment? We prayed and we wanted this baby so bad. And I don't think it ever should have to be a decision of, I want to have a baby, or do I want to be alive? I gave birth in August, early August, and in mid-November, I was diagnosed with acute heart failure. Immediate thoughts were, you must have the wrong person. I'm the face of the Heart Association, so to speak, in our area, and how could this happen to me? Or how could I allow this to happen to me?
The only thing I heard was heart failure. Like, I know she told me probably 3 sentences, but the only thing I heard out of those 3 sentences was heart failure. And then, of course, my mind is thinking, the worst. Like, I can be there emotionally, and, but I couldn't fix it. And that feeling of being helpless, that was the worst part, because it's like, I can't do anything to fix this. And that was something that was hard to deal with.
Without the American Heart Association, I would not have known to go and check my blood pressure. Really listen to your body. Like, we know when something is not right. My mom was here visiting and visiting with the baby, and just thought maybe I was tired or dehydrated and thought to lay down. But just always listen to your gut is the thing I would tell other women.
I'm so proud of my wife, as far as everything she's been through and still being able to be there for me and baby Ava. And I know she knows that, but I just wanted to say that I'm very proud of her.
We want Ava to know that we love her and we wanted her. We planned for her. We prayed. Yep. We created a home together, even with everything that's happened and going on. Like, we're so excited and hopeful for her future and our future.
So you've just seen and heard of two women who were sent home, who were misdiagnosed, who were not listened to, and just had medicine to go home and told to go home. I know that this has been a long day and this has been a lot of information. And I want you to again think about what you've heard throughout this day, starting with Bishop Riddick, and what you've experienced, what you felt when you've heard the testimonials, when you've heard the information, and carry that with you. Take that with you and decide what you are going to do to take the next step. What is your next step? That's what we're going to be discussing tomorrow after the prayer breakfast. I want to thank again the pastor and host of this great church, Bishop Riddick of Gethsemane Baptist Church, will be here tomorrow. Thank the AV team. Thank the team who has put this together. It takes a village, and now I think that we are the village. And I want to thank all of you for your passion, your commitment, and for making sure that we are standing up for people who cannot stand for themselves. We are giving a voice to the voiceless. We are putting into action things that people dream about. And we can only do this work together. So thank you all again. Look forward to seeing you. For those of you who are joining us at Sauté, you can head over now. It's available, and I think the invitation said 5:30 to 7:30, but I understand that some people have already gone over. Please, okay. Some people have already gone over. That's fine. Have a chance to network. Bring your topics of conversation. We look forward to seeing you tomorrow.